I can't talk now, I'm sorry. Thank you, Commissioners. Before we broke for morning tea, Ms Heckenberger, if I could address this question to you. I was asking you some questions about what options were available to you as the Regional Director in light of the October 2018 audit results. Firstly, it's evident, is it not, that whatever improvement plans had been put in place in response to the February 2018 audit had not been successful.
That's correct.
Yeah. Part of the implementation of any improvement plan in response to a mock audit, there was a key role played by the General Manager of the facility. Would you agree with that?
That's correct.
And we heard earlier from Ms Westholz that the previous facility manager had departed around this time. Is there a relationship between those two events? Without necessarily going into detail, was there perception by you that at least part of the reason for the failure to address the February 2016 defects was because of the facility manager?
That's correct.
All right. A new facility manager, Mr David Neal, was employed he commenced in January 2017?
That's correct.
Did you employ him, Ms Heckenberger?
I did.
And are you able to recall now how many applicants there were for the position?
No, I don't recall that.
Doing the best you can, was it a case where there were, only 2 or 3 applicants, including Mr Neal, or did you have a dozen, or are you just not able to assist us?
I really can't recall. Recruitment was really managed by HR in the application process.
Okay. Did you interview Mr Neal for the position?
I did.
And why were you prepared to employ him as facility manager? In other words, what qualities did he display that convinced you he was the right person for that role?
He was currently working in the home as care manager,
Yes.
so that is a senior clinical position within the care home. Feedback from families and from team members was positive about his leadership. He had previously managed a care home in Queensland, and so the continuity of having an internal applicant was favourable.
If we could have tab 10 from the tender bundle displayed, please, on the screen. That's the first page of the October 2016 audit. Mm-hmm. And once again, we see the risk calculator was very similar to the risk calculator for the February 2016 audit. Do you see that?
From the table, yes, it's very similar.
Yeah, overall rating once again was red. From your experience, Ms Heckenberger, was it normal to have 2 mock audits within the 1 year at a Bupa home?
No, that was very unusual.
The standard practice was to have one every 3 years in advance of an accreditation audit, is that right?
That's correct.
Might be better to direct this to you, Ms Westholz. The reason there were 2 in 2016 was largely because of you wanting to have the one in October, is that right?
Yes, that's correct.
And Ms Westholz, when you saw the results of the October audit, you would have been deeply concerned about the clinical performance of the Bupa South Hobart facility, I take it?
I was.
And it's important, isn't it, for us to understand that even though this is a paper process, ultimately what's being measured is the care that's being provided to the residents. Is that right?
Exactly.
Yeah. So when we talk about a failure to comply, for example, with outcome 2.10, nutrition and hydration, when that's boiled down to it, that's feeding residents and giving them enough to drink. Is that right?
It can be part of that, yes.
Yeah. And for there to be a constant failure through 3 audits from November 2014 through February 2016, October 2016, in relation to that outcome, nutrition and hydration, that really does suggest a fundamental problem, does it not?
Yes.
I asked you earlier, asked Ms Heckenberger, but I'll address it to you, Ms Westholes. An option that was available within Bupa's clinical governance framework was a clinical governance review. Is that right?
Yes.
And as I read the instruction, such reviews are directed at cases of non-compliance with Standard 2. Is that right?
That's correct.
And wasn't that what you were looking at here with these 2 audits in February and October of 2016?
I was actually also interested in the overall compliance against all the standards,
Yes.
as well as Standard 2.
But the bulk of the non-compliances, the reds on that table, were in Standard 2, weren't they?
Yes.
Yeah.
Yes.
Did you give any thought to a clinical governance review being carried out, Ms Westholes?
I was asking for the mock audit because that was my understanding at the time
Yes.
of the correct way to go.
All right.
Yes.
So I'm just trying to understand why you wouldn't avail yourself of such an opportunity. That is a more specialised, deeper dive, I think, is the way one of the witnesses refers to the clinical governance review. Why wouldn't you take advantage of that in light of these outcomes?
My thinking at the time was across all of the standards as well as Standard 2 because they all impact each other. And I do find that the mock audit did give me considerable information on our compliance or lack thereof against Standard 2 amongst the other standards.
Ms Heckenberger, is there anything you could add to this? Did you consider whether a clinical governance review ought to be conducted?
My understanding is that a mock audit is far more thorough than a clinical governance review across Standard 2. It also extends to include the other standards. It takes approximately 3 times as long to complete by the auditors. It supersedes the CGR in its capability to provide information to the home. It's a far more thorough audit than the CGR.
Okay. Now, if I could change topics and ask you some questions about Bupa Model of Care 2. We also have references to Project James in the evidence that's been provided to the Commission. Ms Heckenberger, are they the same thing, or is there a subtle difference between Bupa Model of Care 2 and Project James as you understood it?
My understanding is that Project James refers to a specific later part of the rollout of BMOC 2.
Are you able to summarise for the Commission your understanding of what BMOC 2, what it consisted of? What were the parts of BMOC 2 that differentiated it from BMOC 1?
So there was the reduction in the clinical manager role, the removal of that from the organisation.
Can I just stop there? So previously under BMOC 1 there was a clinical manager role and a care manager role, is that right?
A number of care manager roles in the home depending on the size of the home, yes.
Okay, so can we just focus on Bupa South Hobart for the moment, which the Commission has visited yesterday. It's got 3 buildings, 2 of which are attached and 1 is separate, is that right?
That's correct.
And are you able to tell us before BMOC 2 how many clinical managers were employed there? Was it just the 1?
Just the 1, yes.
And what about care managers?
There were 3 care managers.
1 for each building?
1 for each building.
And the clinical manager role and the care manager roles were filled by registered nurses?
That's correct.
And so part of BMOC 2 was a reduction was the abolition of the role of clinical manager, is that right?
That's correct.
Okay. So that's a removal of 1 registered nurse professional from the home?
That's correct. It should have also included a removal of a care manager role as well.
Yeah. In its purest form, it should have reduced the number of care managers at Bupa South Hobart to 2.
That's correct.
You, however, were concerned that that would have a deleterious effect on care?
I was very concerned, yes.
Why was that?
Historically, the home had struggled to have a pool of qualified registered nurses available. Clinical leadership had been something that had been lacking in the home, and Liz and myself had been working very tirelessly to grow the capability of the leadership team. I believed very strongly that that was going to have an impact on, firstly, the leadership, but also from time to time the care managers would cover a registered nurse role if we were unable to find a replacement. And I believed it was fundamentally important that we had resources within the home to ensure that clinical care was being provided safely.
Now, BMOC 2, according to the evidence we heard yesterday from Dr Monks, was essentially about saving money. Is that right for Bupa? Is that a fair summary?
I think it's a large part of the summary. I certainly received additional information about the change in the model of care. BMOC stands for Bupa Model of Care, and
yes.
so it was. It also included a model of care change, not just a financial benefit, but financial benefit was certainly part of its purpose.
I want to ask you about a couple of emails that you received and sent, which seem to be relevant to this BMOC 2 process. First one is tab 23 in the tender bundle. Whilst that's coming up, you'll see it's an email from Ian Burge. He was your direct report, is that right? You were reporting to Mr Burge as the operations manager? Have I got the title right?
Director of Operations,
Director
yes,
of Operations.
that's correct.
Thank you. And we see this was an email that was sent to all general managers, so that would have included Mr Neil, for example, at Bupa South Hobart, is that right?
That's correct.
All regional support managers, so that would include you, Ms Westholes?
That's correct.
And all regional directors, that would include you, Ms Heckenberger, is that right?
That's correct.
And it was an email sent by Mr Burge, as we see, 9 May 2017. Hi everyone, thanks for your time again this afternoon and yesterday. It's a bit out of cycle to have 2 calls in 2 days, but with Jan in Sydney, that's Jan Adams, is that right?
That's correct.
And our need to move with urgency to improve BACA's commercial position. BACA is Bupa Aged Care Australia.
That's correct.
I felt it warranted another discussion on our current context and how we're going to move forward. Without going through this entire email, is it a fair description of this time in Bupa, that is May 2017, that there was a clear direction coming from head office to the regions and to the facilities of the need to cut costs?
Yes, that's correct.
And the way that was to be done is set out further down this email in a paragraph that starts halfway down the page. The immediate ask, while longer term options are looked at, is to make a slight adjustment to shifts, to claim accurately and to only spend where necessary. And then you'll see 3 dot points depending on the size of the home. If we could focus on the middle dot point, because Bupa South Hobart had 119 beds, is that right?
That's correct.
So it fitted into that second category. If you're an 81 to 120 bed home, we ask you to save equivalent of at least 2 shifts, 2 by 7.5 hours a day. If I could just pause there for a moment. That's a reference to an initiative called Save a Shift, under which a person, an employee who called in sick, for example, wouldn't be replaced for the day. Is that right?
That's correct.
You say in your statement, Ms Heckenberger, and it's referred to in this email, that that was only to be implemented in circumstances where it would not have a deleterious impact on care. Is that right?
That was the directive, yes.
I want to ask you about that. That rather assumes, doesn't it, that a home would have to be overstaffed, for example, for it not to impact on care.
It does.
Were many Bupa homes overstaffed in May of 2017, do you think?
My recollection of the time is that occupancy was lower than expected. So it is likely in some homes that there were resident numbers lower than anticipated and rostered to, yes.
So it would be only in a home where occupancy was less than, high 90% that would apply. Is that what you're saying?
It would depend on what the budgeted occupancy of that home was, yes. But if it was below budget in occupancy, there would be an expectation there, yes.
I'll be corrected if I get this wrong, I'm sure, but at this time, my reading of the documents is that Bupa's occupancy rate was generally very high. South Hobart's occupancy rate was generally very high, around about 118 or 119, nearly complete occupancy.
Yes, so when I started, there were 13 residents below budget, but certainly by this time the home was now full, yes.
Yes. So if that's right, then it wouldn't be possible, would it, to save a shift at Bupa South Hobart without having at least some impact on care? Do you agree with that?
I agree with that.
Yet this was a directive that was being given to apply across the board within Bupa, wasn't it?
It was, yes.
Were you, during this process, feeding any information up to the executive level, raising concerns about how this initiative or these initiatives would impact on levels of care at Bupa South Hobart?
Yes, certainly about my homes generally, yes. So there were detailed discussions between myself and Mr Burge, sometimes daily, about the context of what was being requested of us and what that meant in impact on the ground.
And were shifts saved at Bupa South Hobart pursuant to this instruction?
I don't recall a significant amount being saved. I think there might have been some savings in the laundry and possibly in cleaning, but I don't have any access to my records, so it's my best recollection.
Returning then to that second dot point, after the reference to saving shifts, a $3 uplift per occupied bed day, that's a reference to increasing ACFI payments, is it?
That's correct.
And am I reading that correctly? There was a directive, was there, from head office that there was to be a $3 uplift in ACFI payments for each resident in each bed. Is that right?
I would say it was a directed goal.
How was that to be implemented as you understood it, Ms Hickenberger?
In my understanding, it was for the General Manager to lead a review of resident assessments in line with their care needs in the home, to assess any care requirements above their current ACFI claiming, and to ensure that assessments and claims were updated to reflect the resident care, and to ensure that the organisation was receiving government funding for the care it was providing.
I'm just trying to understand that. So the ACFI payment could only go up if the care needs went up.
Correct.
And if the care needs went up, then more care would need to be provided to the resident in line with the increased ACFI payment.
It would sort of happen, in my experience, it would happen the other way. So generally, care requirements would increase naturally. Care teams would provide increased care, and there was often a lag in the application for increased funding in the daily practice of a care home.
But to the extent that the funding increased, reflecting increased care needs, it would be incumbent on the homes to correspondingly increase the amount of care, would it not?
If they were not providing that care, yes. Definitely.
I'm trying to understand how that notion fits with the reduction in nursing staff, for example. Is there a tension there, do you think?
In my experience, care is provided by people, so any shift in resourcing has a direct correlated impact on resident care.
We've already seen that the audit history at Bupa South Hobart indicated deficiencies in a number of areas of clinical care. Do you agree with that?
I do, yes.
And we've seen that at least in September 2016, Dr Monks was raising concerns along similar lines with you. Do you agree?
I agree.
I'm trying to understand how, against that background, you would consider reducing nursing numbers at Bupa South Hobart. Are you able to assist me?
So that was my point exactly with the retention of the extra care manager. That was what I was proactively and fiercely advocating for, was the retention of the third care manager.
Yes, but the clinical manager was gone.
That person stayed, the role was made redundant, yes.
Yes. So can I just clarify that? So you're putting the care manager situation to one side, you're immediately down a nursing position, are you not?
A leadership position, yes.
Yes, and an important leadership position according to Dr Monks's evidence yesterday, as one could imagine, for the GP. Do you agree with that?
I would agree that that's her opinion, yes.
But it's not just her opinion, is it? Doctors need nurses to assist them with their work, do they not?
They do, yes.
So the Commission is keen to understand how it was considered to be an appropriate initiative to implement to reduce a nursing position, and there was also subsequent reduction in nursing hours, was there not?
Not during my time, no.
I see, that came after, did it?
It did, yes.
All right. So how is it that the internal governance framework for clinical care at Bupa allowed reduction in a nursing position and then subsequently nursing hours in the face of the audit results, which we've talked about? Do you understand my question?
I do understand your question. I'm just not privy to that information. I was not a part of the ELT. I don't understand how that decision making was arrived at.
I understand that. I'm not suggesting for a moment that it was a decision you made, but ultimately you were responsible for implementing it, were you not?
I was, yes.
Yes. And did you convey, so withdraw that, you did convey your concerns about the reduction in care manager positions?
I did.
Beyond that, did you raise any other concerns with your superiors, with Mr Burge, about the potential impact on care at Bupa South Hobart of Save a Shift and these other initiatives that we've discussed?
I would have on several occasions.
And what was the response?
There was certainly a sense that that the group as a whole would adopt this, and that would have greater and lesser impact in the different homes. I was successful in my advocacy for retained team members in Hobart. I was able to communicate the need for that successfully, and therefore it was outside the clinical manager during my time, not impacted with any reduction in nursing hours.
Can we go to the next page of this email, please? About a quarter of the way down, you'll see that Mr Burge wrote to you in the first complete paragraph there are no sacred cows and anything's possible. So when it comes to rosters, for example, the easiest way to save 1, 2 or 3 shifts in relation to non-replacement of annual leave. Stand by the reference to there being no sacred cows and anything's possible, Ms Heckenberger?
I don't have a definition of what he meant when he wrote that.
Well, I suggest to you that what he meant was that in Bupa's efforts to reduce costs and improve the commercial position, that it was effectively open slather, wasn't it? Isn't that what anything's possible means? Do what you need to do? Is that a fair description?
I personally didn't take it as that, but I can understand that it could be read as that.
Well, you were, I suggest, Ms Heckenberger, a pretty enthusiastic implementer of this initiative within your region. Do you agree with that?
No, I don't agree with that.
All right. Perhaps I'll ask you to have a look at tab 24, please. This is an email that you sent 2 days after you received Mr Burge's email on the 11th of May 2017. It's addressed to Region 4 General Managers. Was that your region, Victoria,
it
Tasmania?
Was.
Okay,
that's
so
correct.
That's including Mr Neil at Bupa South Hobart?
Yes, that's... at that time, some of the people attached in that, my region is extended at that time So I must have been caretaking a second region at that time.
Is that when you went from 10 to 14? Pat?
No.
Is it? No.
No, that was just an interim. Somebody would have been on leave, and there are homes listed in that email that are not part of my standard region. You see them attached as additional people in there.
I see. You wrote, "Hi guys, thanks so much for your contribution to the GMTC today." That's General Manager Teleconference, is that right? Is that right?
That's right. That might be my personal one.
Yep.
Yep.
I love working with you all, especially in this time of such great opportunity. Keep up the fantastic work you're doing. And then in bold you wrote, "Remember there are now 2 key KPIs, that's key performance indicators, is that right?
That's correct.
That you'll be measured on. 1, save a shift, 1, 2 or 3. 2, ACFI uplift, $2, $3 or $4.
That's correct. They were outlined in Mr Burge's email that we reviewed previously.
Indeed. This was an email in which you were effecting the directive that you received from Mr Burge, is that right? Implementing it.
It was a follow-up teleconference with my general managers, yes, post that call, and a reiteration of what they'd heard on that call, yes.
What did you mean when you said there are now 2 key KPIs?
Well, they were the 2 KPIs that were noted on that call.
Perhaps that question wasn't clear. Are you suggesting these were now the only 2 KPIs that the general managers would be measured on?
I don't believe so, no.
Okay. They were additional ones. Were they beyond their existing performance measures?
Yeah, I'm trying to draw my best recollection. I believe they were now the 2 clear KPIs that had just been given to us in that previous general manager call.
It's pretty clear, isn't it, from this email that you were asking the general managers to focus their attention and enthusiasm on these initiatives. Would you agree?
Focus their attention, definitely, yes.
You went on, "I'd like to be able to report to you each Friday on how we've gone saving a shift a day. So please fill out the following table each Friday and send it back to me each Friday every week." You see that?
Yes, I do.
There's nothing there at all, is there, about only saving a shift if it doesn't reduce care?
No, there's nothing in that. I'm not sure of the bottom of that email, but I don't see it, no.
I ask you to accept there's nothing on the second page
Yeah.
that would suggest that. Why didn't you include that in this email?
I'm not sure. I don't know why.
Can I suggest this, Ms Heckenberger? You knew that it was, for all practical purposes, impossible to save a shift without reducing care levels in the homes that you were responsible for, didn't you?
I don't believe that I made that decision in writing that email to omit that on purpose for that reason.
No, I'm not asking you what reason you had for omitting it. I'm asking you whether it was your state of knowledge at this time that you knew you couldn't cut shifts without reducing care levels, didn't you?
Possibly.
Yeah. Well, we already heard the evidence from Ms Westholes about the roster problems at Bupa South Hobart, that it wasn't full at least at the end of 2016.
That's
Recall
correct.
that? Yeah. And I suggest to you that within Bupa at this time, the clear directive that was being passed on to facility managers from the executive level was that people who went off sick, staff members who went off sick, would not be replaced as a way of saving costs. That was the clear directive, wasn't it?
It was.
Yeah. And that could only exacerbate the problems with care, and particularly clinical care, that had been revealed in the audit history at Bupa South Hobart, couldn't it?
Yes, that's correct.
I just want to ask you about one further email shortly after this. Is at tab 30. An email to you from Daniel Thomas. Mr Thomas was in the commercial finance team at Bupa, is that right?
That's correct. He was my commercial business partner.
Yeah, and that's where these initiatives were being driven from, isn't it? The commercial finance department at Bupa?
They were our resource for commercial information, yes.
and they were driving BMOC 2, Project James and Save a Shift.
No, that's not correct. He was my commercial information provider. He was not involved in any operational decision-making or projects.
I see.
Yeah.
Those decisions were coming from Mr Burge, were they?
That's correct.
Is that right? Okay, thank you. And you'll see that Mr Thomas wrote to you in response to concerns that you had raised. Perhaps we start there on the second page of the email. You wrote to Mr Thomas copying Mr Burge on the 27th of June. Hi Danny, thanks for sending this through and for all your work on it. That was a reference to a proposed roster, is that right?
Yes, this is actually separate to Save a Shift or BMOC. This is a discussion, an ongoing discussion about the roster at Bupa South Hobart.
And without reading all of your email to him, you were raising a concern that in the proposed roster, it wouldn't save enough money.
That's correct.
Yeah. And that was a response by you to your understanding that that's what you were being required to do?
Part of my responsibility was to improve the commercial operation in South Hobart. As noted in that email, staff costs were about more than $650,000 a month. In the prior 2 months, that had been overspent by a further $175,000 per month, and we were looking to deeply understand how the cost generation of wages in that home was so excessive.
What we don't see in these emails, and perhaps you can direct me to where we might find it, is any consideration of the likely impact on care at Bupa South Hobart by these initiatives. Where was that consideration at this time?
This was a fact-finding relationship with the commercial business partner. Danny was not involved in any way in either resident care or in operations in the home. So this was us exchanging information about how the roster had been built, where the excess hours were coming from, and what we needed to do to enable this home that was losing money every month to come back from that position to a neutral position in the long term.
I understand that, but the Commission's concern is, of course, with the quality and safety of care that was provided at Bupa South Hobart. This is all occurring against a history of serious concerns about care levels, isn't it?
Yes, it is.
And so where do we see in the records of the implementation of these programs you or anyone else raising a concern about the effect, the potential effect on care levels of these cost reductions?
I don't have access to my emails or files from that time as I'm no longer at Bupa. There would be several communications with my urging strongly about the impact of this and the ramifications for clinical care in the homes. Hence the success in retaining the third care manager.
Yeah. If we just go back to Mr Thomas's response to you, so he's responding to your concern about not reducing costs enough. And he wrote, "Hi Steph, yes, I completely agree and believe to truly achieve a result at South Hobart, we need a new philosophy moving forward. The only philosophy I believe that will work is completely forgetting about BMOC roster." I could just pause there, BMOC rosters rather. That's a reference to BMOC 1, I take it. Is that right?
Yes, general BMOC rostering, yes.
Okay. And the evidence that we've heard, and I think you agreed with this, is that the BMOC rosters were implemented as part of a policy of ensuring person-centred care was provided to the residents in the Bupa homes.
Yes, that's correct.
And then going back to what Mr Thomas said, he said, that sounds like a big call, but if we want to save on staff costs, we need essentially to cut hours gradually month on month. In my opinion, this is the only way forward, each month having used fewer hours than the month before. If I just pause there, that was just a recipe for disaster, wasn't it?
Again, Danny is not involved in operations. He's in the financial commercial team. He's making commentary about the financial strategy rather than a resident-centred strategy.
So what's your evidence to this commission? Having received this email from Mr Thomas on the 28th of June, did you seek to implement those suggestions?
No, Danny's recommendations were not in any way considered to move away from BMOC. That's beyond my role. That was just something that would not be considered in Bupa.
I see. So that might answer my question about the last line where he asked you at the very bottom of the email, hope this isn't too controversial, happy to talk through whenever you're ready. Is your evidence to the Commission that it was too controversial?
Yes, and it was not considered with any serious nature.
I see. Now, if we could move forward to a further communication you received from Dr Monks. This is at tab 36. Without going into the detail of this, you're familiar with this email, Ms Heckenberger, are you not?
I am.
Yeah. And once again, Dr Monks was raising concerns similar to, but perhaps not as strongly expressed as the ones in the September 2016 email to you.
That's correct.
And in your supplementary statement, which I don't need to go to in detail, but I note that you have addressed the response to this further email from Dr Monks. That's the case, is it not?
That's correct.
And you turned to Ms Westholz for to do some investigating of the concerns raised by Dr Monks.
That's correct.
And Ms Westholz, you refer in your statement, this is at paragraph 75 of the statement on page 14, to Ms Heckenberger having passed on to you the concerns that Dr Monks had raised. Is that right? Do you see that in paragraph 75?
That's correct.
You were RSM, and then perhaps 76 might be better. You refer to this email from Dr Monks, which had been passed on to you, and you carried out some investigations, did you not, to assess whether or not there was cause to be concerned?
That's correct.
And ultimately, it's the case, is it not, that you were able to confirm that at least some of the concerns raised by Dr Monks were legitimate concerns about clinical care?
That's correct.
Now, there was a discussion at this time with the CSI team, Ms Tierney, is that right, Ms Heckenberger?
Yes, that's correct.
Petra Tierney, she's from the CSI team.
She is.
And she proposed, did she not, a clinical governance review in response to the history of audits and now these new concerns being raised by Dr Monks?
That's not correct. I requested we spoke at length about a CGR.
Yes.
And she offered to do one, yes.
Yes, okay. And were you willing for that to occur?
Yes, absolutely.
I suggest to you it was probably overdue by this time, wasn't it? Do you agree with that?
I'm just thinking of the time frame. Previous to that, we'd had a visit from the accreditation agency with a compliant to 2.4 clinical care.
Yes.
It was an appropriate time to review again, yes.
All right.
Ms Heckenberger, perhaps I could ask you a more general question about this. I'm assuming that nobody really wants sanctions. With the benefit of hindsight, what do you think could have been done better?
I have spent time thinking about that myself, and my experience in the home was that it was a regular process of failure, identification, rectification. What was missing was the onboarding of that process as a sustained process. So the home kept lapsing back into non-compliance, and a program to have embedded that more deeply and more sustainably in the team was what was missing in the process.
And how would one have embedded it more deeply? I mean, you had any number of formal written policies about what should and shouldn't be done, and obviously people had thought about the theory of what should and shouldn't be done, and it was not quite working. So what was it that was the bit that was missing?
Again, I believe the ability to grow that consistent capability in the team that retained over time.
Thank you.
Thanks.
Could I perhaps pick up on Commissioner Pagoni's question, which politely suggested that the system wasn't working as well as it could have been, if I can paraphrase. It's worse than that, isn't it, Ms Heckenberger? This history demonstrates some fundamental failings of clinical governance. Do you agree with that?
I do.
Because we know where all this ends. This ends with the audit in October 2018, which is the worst of all the audits and, of course, leads to sanctions. So from the Commission's perspective, we need to try and understand why in a large organisation such as Bupa, with access to not only resources in Australia but overseas, and with what looks like a really good clinical governance framework on paper, why didn't it work? I know you've had a go at answering that, but was it the structure that was inadequate, or was it the way it was implemented, or was it the people, or some combination?
As a non-clinician, I feel it was the assumption that the completion of an action plan meant that the home was going to remain compliant from that point on. And the completion of the action plan only rectified the errors up until that time, and once that intensity was taken away, the teams would revert to poor practice.
So is that because the audit reports produced an action plan that people didn't know what they were supposed to do? Were the lines of communication and responsibility clear from the action plan? It's important to get a sense of why what look like good strategies and systems can not work.
In Hobart, it was particularly difficult with the moving of team members and people within the organisation. And just providing consistent care, the amount of training that was provided to team members that 3 or 4 days later had reverted back to old practice was continual, was just constant.
But would people know what their responsibility was, and when there was a movement in the team, did they know did the new person in the team know what his or her responsibility was?
I don't believe clearly enough. And it's a 24-hour business, so many of the team members are there when there's no leadership in the home.
I see.
Can I suggest another reason, perhaps the elephant in the corner of the room? Against a background of audit failures and a doctor raising concerns, there was a strategy which was aimed at reducing staff, cutting particularly nursing staff, the very people who would be expected to address the concerns identified in the audit. That's got to be part of the problem here, doesn't it, Ms Heckenberger?
I would agree with that completely, yes.
Yeah, it was a completely misguided strategy, I suggest to you.
It felt like that at the time, yes.
Ms Westholz, I think you're keen to add something there, are you?
I would agree with that comment. It was Hobart has always been that challenging home, as Steph had said, is compliance and then reverting back due to the constant changes in key personnel, leadership, clinical managers that has existed since I've been involved with the home.
Understand that. There's also the challenges of the building layout itself, aren't there? But all those things just really emphasise the point I'm trying to make, don't they? That you wouldn't just cut staff across the board without considering the likely impact on a particular home of doing that. Do you agree with that?
I would agree with that.
You're still there. Do you think that lesson's been learnt at Bupa?
I'm not still at South Hobart.
No, I understand that.
But with Bupa, yes, I do believe so, as seen by a number of initiatives and changes to how we do things.
Commissioners, they're the questions that I have for this panel.
So let's go back to those questions that you're both talking about leadership, staff moving constantly and so on. So am I correct in saying that the leadership was also moving and was unable to work sufficiently closely with a constantly turning over or churning workforce to embed the kinds of cultural and care changes you would expect to see to deal with the problems?
Yes, I would agree completely with that.
Yes, I would certainly agree. And then you have the other challenge, Commissioner, when you've got a whole lot of new people coming into the home all of the time. Who is budding them? Who is training them? You're not getting that continuity of our person, our cultural aspects that we want to implement.
So fundamentally, the staff weren't being consistently supported and guided through the learning processes that would have been necessary to embed the kind of changes that you both sought to implement as a result of the audits.
That's correct, yes. Training was provided extensively, but it was not having the impact that was required. And again, the volume of change in the team members meant that the team members didn't understand deeply and innately the individual care needs of the residents, and to be able to provide that person-centred care that was so important for the vulnerable residents.
So can you explain to me, why was that the case? Did the residents have care plans that were updated, or was it just a constant churn of staff?
Did they have care... Sorry, can you repeat the question?
Did the residents have care plans that were updated according to their particular and specific care needs? Or what was the problem that the staff didn't implement changes consistent with their care needs?
In my experience, again, as a non-clinician, I would say that the care plans contain care detail that is about the health needs of the residents. The human-centred interaction that team members have with residents is about how they like things to be done, who they are as people, what's important to them at a human level. And that's very difficult to provide consistently on a transient workforce.
Yeah, Ms. Wessel?
In my view, yes, there certainly were care plans, but it's with the churn, the constant movement, especially of clinical managers, care managers, and leadership in the home. Care staff need to be supported, need to be, for want of a better word, monitored, and practices discussed and open communication around that. So that leaves in my experience, quite a gap when you have inexperienced or new people constantly coming into that role. It's the supervision and support that really goes missing very quickly.
And what was apparent from our visit to the home was not only were there 3 separate buildings, but even within the one building, it was hard to see or connect with anybody. Yeah. So
Yes.
the structure was a problem, as Council said.
Yes.
Yeah.
That's correct.
Thank you.
Thank you.
Yes, thank you. Well, thank you both for giving your evidence. It's been informative, and you're excused from further attendance.
Thank you.
Thank you.
The next witnesses are Ms. Davida Webb and Ms. Linda Hudek. I think there may be an appearance to be announced for Ms. Hudek.
Yes, Mr. McKenzie.
Repeat after me. I solemnly and sincerely declare and affirm
I solemnly and sincerely declare and affirm
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Repeat after me. I solemnly and sincerely declare and affirm
I solemnly and sincerely declare and affirm
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Do please feel free to sit down and make yourselves comfortable.
If I could start with you, Ms Webb, could you please state your full name for the transcript?
Davida Alexia Webb.
Thank you. And Ms Webb, you have provided us with, provided the Royal Commission, I should say, with two statements, is that right?
Correct.
There's an initial statement dated the 4th of November 2019, which is WIT.0608.0001.0001.
Correct.
Have you had an opportunity to read through your statement dated the 4th of November 2019 before giving evidence?
Yes.
Is there anything in it that you wish to change?
No.
I tender the statement of Davida Webb dated the 4th of November 2019.
Yes, that statement will be Exhibit 13-28.
Thank you, Commissioner. And you've provided another statement more recently dated the 12th of November 2019, WIT.0608.0002.0001. Is that right, Ms Webb?
Correct. Yes.
And is there anything you'd like to change in that statement?
No.
And are its contents true and correct?
To my knowledge, yes.
Tender the statement of Ms Webb dated the 12th of November 2019.
That'll be Exhibit 13-29.
And Ms Hudek, is that the correct pronunciation?
Yes.
Thank you. You two have provided us with two statements, although the second one is a corrected version of the first.
That's correct.
For reasons that I don't need to go into with you, they'll both be received. They've been separately coded, so we'll deal with them one at a time. The first statement which you signed was dated the 4th of November 2019. It's WIT.0610.0001.0001.
Yes.
And it's apparent from the further statement which has been provided to the Royal Commission this morning that there are some additional matters and some corrections to that statement that you wish to make.
Yes, that's correct.
Rather than going through those one at a time, which will take quite a while because there's a number of changes that you wish to make. And it's fair to say, isn't it, that some of them are substantive, they're not correcting typographical errors.
No, that's right.
They're changes to your evidence. And so you would ask through your lawyers, I understand, for us to accept a revised version of that statement, which is dated the 14th of November 2019, and it's coded WIT.0610.0002.0001.
Yes, that's correct.
It's not an ideal situation, Commissioners. I think what is expected.
I think it's positively undesirable, isn't it?
I haven't had an opportunity to speak to my learned friend, Ms Mackenzie, about what is intended. I gather what's intended is that the second revised statement replaced the first.
That's right.
The difficulty is the first was signed and received by us.
No, but if there are errors in the first, it ought not to be received. And indeed, if you ask the question, is the first an accurate statement, the answer is going to be, well, no, it
I
needs to be
anticipate
changed.
that's the case.
So unless you don't want the second one to go in, the preferable course is for the second one to go in, and if you think there are real errors in the second one, then you should put it in cross-examination.
No, I don't. I'm not of the view that there are errors in the second one, and in those circumstances, the best course would just be to tender the second one
I think so.
and not receive the first one.
I think so. And there'll be the lunch break, so that if you're wrong about that, you can come back and fix
Yes.
it. But that would be
I
the
might just
preferable
glance down the bar table and see if Ms Mackenzie's happy with that approach.
Sorry, I'm having trouble hearing.
course. So the approach that's proposed is that the second statement go in and not the first statement.
Yes, that's correct. That's what was intended.
Okay. Ms Hudek, you're the most important person in the room about this topic. Is that what you would like us to do? Receive the second statement, disregard the first?
Yes, thank you.
The second statement, I take it, is true and correct with the amendments that you've made. In those circumstances, I'll tender the second statement.
Thank you. Well, that will be Exhibit 1331.
Commission pleases. And I think I read out the code for that. If I didn't, it's WIT.0610.0002.0001. Ms. Webb, can I start with you and ask you a little bit about your background? You're a nurse by training.
Correct.
From the old pre-university training days.
That's where I first started, correct.
You did your training back in the early 80s.
Correct.
And have been a registered nurse formally since 2003.
Correct.
Okay. You've listed some other qualifications which I won't take you to in your statement at paragraph 8. And you are presently working as an aged care manager in Queensland, and you've been doing that since September of this year.
That's correct.
I notice in your statement you say that you manage 15 homes in that
Correct.
role.
Yeah.
And it being Queensland, I suspect they're spread out over quite a significant geographical distance, are they? Or are they in
reasonably. Through Gold Coast and Brisbane, there's the biggest component, which they're about an hour and a half drive, I suppose, in a radius. Then there's in Toowoomba and a couple further regional north.
Were you in the hearing room when the previous witnesses were giving evidence?
Yes.
And they both made the point that the 10 to 14 homes that they were responsible for on a regional management level stretched them in ways that impacted on at least the care levels provided at Bupa South Hobart. From your current experience, are you able to assist the Commission? Are you able to fulfil your role satisfactorily across 15 homes?
This role is quite different.
Is it?
In that, as the aged care manager, I oversee them, but there's a team underneath me that works with me to do that. The team consists of an operations manager, a quality and governance person, a manager, and 3 regional support / governance care coordinators that filter around those 15 homes. So they work about 1 to 5, and one might have 6, and the other one's got 4.
I understand. Now, you worked at Bupa between 2009 and 2018, is that right?
Yes, 19, sorry. 19. Sorry.
You've worked in a number of roles which you've spelled out in your statement, which I won't take you to, but it culminated in being the head of operations between July 2018 and July 2019.
Correct.
You also spent some time as a regional operations manager in Queensland for Bupa between 2013 and 2018, is that right?
That's correct.
In your statement, you described the Bupa South Hobart home as a particularly serious or problematic case. Do you recall using that expression?
I think, so I didn't look after that home for a long time, so I came into head of operations when it was became under my remit then. But with the operational meetings that we were having, we would have those monthly, and down in Sydney, and Hobart was one that was commonly mentioned in that as problematic.
And can you assist us with when that was? Was that when you're performing a head of operations role?
No, it was regional director. Operations manager, regional operations manager and regional director are the same role,
yes.
Different titles, so as regional director.
In Queensland, is that right?
Yes,
between
correct.
2013 and 2018?
Yes.
And who was raising concerns about Hobart being problematic, do you recall?
The operations manager at the time, it would have been. When we had our operations meetings monthly in Sydney, we would go through homes that were needing additional attention or any concerns.
And what forum is this that these discussions are taking place in?
So it was the operations meeting, it was classified as, which was led by the operations director, Mr. Burge, and the regional directors of the time.
So that's Ms. Heckenberger's level?
Yes.
Okay. She wouldn't have been there for a number of those years, of course, but that's the level.
No.
Now, Ms. Hudek, can I just turn to you briefly and note that you are also a registered nurse by training?
Yes, that's right.
You have an MBA and other qualifications that
I'm
you've listed?
Working towards an MBA.
Working towards, okay. You started at Bupa in 2011.
Yes, that's correct.
You worked firstly as a general manager at the Wodonga home, is that right?
That's correct.
And general manager, facility manager, are they interchangeable?
Yes, they are.
You worked in a regional director role in Melbourne between 2016 and 2018,
Yes, that's correct.
and then you took over day-to-day management of the CSI team, is that right, in March of 2018?
Yes, that's correct.
And you continued in that role until January 2019.
Yes, that's correct.
And did you hear the description that was given earlier by Ms Wessols of the role of the CSI team in Bupa?
No, I'm sorry, I did not.
So you weren't in the hearing room?
No.
Okay. Can you tell us briefly what you consider the role of the CSI team to have been during that period?
While I was head of clinical service improvement, the role of the CSI team was to conduct some of the internal audits, the mock audits and the CGRs.
Yes.
Making recommendations to the operations team. So when I say operations team, I'm referring to the regional managers, the head of operations, general managers and so forth, in terms of how to remediate those homes. Supporting the organisation with complaints management at a high level. We would offer advice and deal with some of the external to the home complaints that would come through via the Aged Care Complaints Commission or directly into the executive. The actual investigation of those would sit with the operations, with the care homes. Providing reports to some of the committees, quarterly reports to the board of Bupa, clinical governance committees, the risk committee and so forth. We supported with clinical education, auditing and assisting the care homes from an aged care funding instrument perspective. So we had a funding team that would help educate the care managers and help monitor the progress for the funding. I mentioned education, didn't I? Policies and procedures,
Yep.
review of clinical policies and
You
procedures.
do detail a number of those matters in your
Yeah, that's
statement,
right.
and that's obviously part of the evidence. Did you catch the end of the evidence given by the previous
Yes, I did,
witnesses, Ms
yes.
Hudek? You might have heard the questions that were being asked by, particularly by Commissioner Pagoni, about the extent to which the operations side and the CSI side, if I can call it that, of Bupa work together. And perhaps I can start by asking you a general question, conveying to you both the impression I get from the evidence as a whole and from your two witness statements is that the clinical and care audit function, which is your responsibility, Ms Hudek, doesn't seem to have been particularly well integrated into the operational facility management side, which was your responsibility, Ms Webb. Can I ask each of you in turn how you would respond to that? Perhaps starting with you, Ms Hudek.
So I'm sorry, just so I can clarify, you're asking how the CSI team supported that?
Not so
How
much
it
supported,
communicated
but
with
the integration between the two. And the context here is
Okay.
we've got this history of audits carried out by the CSI
Yes,
team
yes.
and improvement plans, but not much improvement on the ground. I'm paraphrasing and summarising. So I'd ask you to comment on your experience of the extent of integration at
Yeah.
Bupa.
So the CSI team would undertake some of the auditing and we would provide advice, obviously. And in terms of the results from those audits, the CSI team would meet directly with the general manager at the end of those audits
Yes.
and have what we refer to as an exit interview to give them a bit of an overview of what their findings were. Those reports would then be sent with recommendations of improvement initiatives to the general manager and the regional manager, and they would commence work in developing a continuous improvement plan to rectify those concerns. Davida and I worked very closely together. We sat in the same office, so we would have lots of verbal conversations about things that we were seeing and hearing out there from an operational perspective. So that was one element of it. When those action plans or those continuous improvement plans weren't completed within the timeframes that was set, that would be reported through to the monthly operations meeting with the regional managers to help understand why things hadn't been completed within that time frame.
Could I just interrupt there, because I think we may have reached a point where there may be a significant issue. So the audits are done by your team.
Yes.
A plan is prepared by your team or by the facility management?
Team.
By the operations
CSI
team
would make recommendations.
to address the concerns raised by the audit team. The expertise, the clinical expertise in the audit team, in the CSI team. After they come back and say, we've carried out the improvement plan requirements, was there any further assessment by you of whether they're actually going to work?
At that point in time, no, there was not. And that was I felt was a fundamental flaw in the auditing process.
Okay, you've anticipated my next question. And because, of course, we've heard the evidence, in one case, admittedly, at Bupa South Hobart, of audit, improvement plan, and then a further audit only 9 months later where things got worse, not better. So that would suggest, at least in that case, that what you've described as the fundamental flaw may well have played a role.
Yes, I feel that my view of the mock audit tool was that it was clearly not effective in what it was intended to do. The mock audit tool, to give you some context, it was intended to assess the care home directly against the aged care accreditation standards.
Yes.
However, as it evolved, this is my understanding coming into the role last year, once we started to unpack that tool, what we found was that the tool actually assessed the care homes directly against the work instructions and didn't necessarily assess against the quality care standards. So it missed that key step, and I think that was just how it evolved over a period of time. We implemented work instructions many years ago, which was a great improvement for Bupa.
Yes.
To standardise and create repeatable processes. But over some years, they seem to have evolved and become very cumbersome, difficult to manage work instructions, particularly for staff on the ground when they need to know how to do a procedure very safely. And it didn't always allow for clinical decision making either, because they were tied to these work instructions. Now, if there was one element missed in that work instruction, it would be considered a partial compliance in the mock audit tool.
I see.
So if there were multiple steps that were missed in the work instruction, it would be considered a non-compliance. And stop me at any time.
No, go on.
It is
I will, but not now.
There's probably a good example. One of the things that I pointed to straight up was the mock audit in July 2018. Bupa South Hobart was considered compliant in the mock audit in 1.4 comments and complaints.
I'll just ask that be brought up so that we can follow this. So this is tab 69, I think. Yeah, tab 69. Did you say July 2018?
Yes,
yeah,
that's correct.
And is there any particular... Well, we see the first page there.
Page 4.
Page 4?
Yes.
So that would be page .8419, please, operator. Sorry, 8418, thank you. And what do you draw our attention to, Ms Hudek?
One of the key elements that I later felt was missing from this tool, given that it was assessing against the aged care accreditation standards, is that it didn't have the guiding principles of each of the expected outcome. So the auditor, who was undertaking the auditor, and the care home managers would look at this tool and look at the first column and would potentially consider that if I have met those things, then I'm considered compliant. And then in the third column, it has the evidence that was used to evaluate against compliance of 1.4. It didn't appear to audit across the entirety of 1.4. My view is that any comprehensive audit tool should also consider critical observation. So what are the auditors actually seeing on the ground? Staff interviews, resident relative interviews of what their experience have been is a very key component, and that wasn't included in here. That would have drawn out a lot more information.
Could I just ask you to move a bit closer to the microphone? I'm being
sorry.
told. Thank you.
I'll shift over this way.
Yeah.
So they were some of the key components that once we began to unpack the usefulness or the whether or not this tool was fit for purpose, they were some of the things that we considered.
So am I understanding you correctly to be saying, in relation to the rating here of compliance with 1.4, which is concerned with comments and complaints, that the investigation required to be conducted by the auditor to assess compliance with 1.4 was less thorough than it should have been?
Yes.
Because, of course, we know that in early 2019, so about 6 months after this audit, consultants were engaged by Bupa,
Yes.
Ms Wilson and Dr Webster, to look at this very issue, that is the complaints handling process at Bupa South Hobart, and they found it wanting in a number of respects. Are you
Yes.
aware of that?
I can't recall seeing their report, but I did see their
Okay.
some of the evidence.
I'll ask you to accept that that was
Yes,
their
yes,
conclusion.
yes.
That seems to make your point,
Yes,
doesn't it? That,
yes.
that this sort of paper assessment doesn't get to the heart of what is necessary. Is that right?
Yes, and there were other elements to it that I felt needed to be improved on as well. It was a singular item that we're using to assess care outcomes at a point in time, as opposed to drawing on a lot of other data and information and joining those dots to give a much bigger picture.
But I think the evidence of both of you is that neither of you were given the July audit, mock audit report.
I cannot recall being given the mock audit.
So that's I think, well, you both say that, I think, in your
Yeah,
respective
correct.
statements. That, how can it be that neither the operations nor the clinical bit of the organisation have got the audit report, the mock audit?
It wasn't necessarily considered standard that the manager of the audit team would escalate these things to me directly as a standard. However, when I reflect on it now and seeing those, the non-compliances, it should have been escalated. But I'm also reflective of the environment at that point in time in which we were operating in.
But what's the point of the mock audit if not either to give it to the clinical services manager or to the operations manager?
I would agree as well, supporting what Linda has said, that in reflection it should have been. I think we entered into the roles at the time where it was really, this was our fourth sanction coming into the business, and I think that, for myself personally, I really feel I was probably firefighting, reactive instead of being more operative and strategic, I guess.
I may have sounded as though I was asking a rhetorical question, but I was actually trying to get some information out of it. Presumably, somebody thought it was sensible and sound for the mock audit not to go to either of you. I'm curious to know what that actually was.
I would agree. I would agree that it's a flaw that we didn't have. It was
But what was the purpose of it then?
It went to the care homes and to the operations managers to enact an action plan and to remediate at the care home.
But not to the heads?
No.
No.
Just before we break, Commissioner, if I could just take up that,
Yes, of
that
course.
issue briefly. If we go back to the first page of this audit that you've drawn our attention to, Ms Hudek, we can see the risk calculator box, which even I can understand is informing any reader of this in July 2018 that the overall risk rating was red.
Yes.
We can see that. And it was the third one in a row that had been done at Bupa South Hobart in a period of under 3 years that had achieved a red result. Wouldn't a pretty simple system be that when you get 1 or 2 or 3, whatever seems the appropriate number of reds, that the case gets escalated to someone at your level?
Yes, I would agree.
Might that be an appropriate time?
Well, I think you should ask the next question. And if that's so, what would be the appropriate number? 1, 2, 3 or 25?
I would say 1.
Yes, 2 o'clock.
Thank you.
Understand? The Royal Commission is now adjourned to 2 p.m. today.
Yeah, I would have gone this.
Silence in the stand.
Resume the hearing, please.
Please be seated.
One housekeeping matter, Mr. Rosen. I think in my enthusiasm for marking exhibits, I may have marked Ms. Hudek's exhibit as 1331 when it should have been 1330. So if that correction could be made, please.
Yes, I think it was 1331. Okay, we'll take that as 1330. Now, before we start, Ms. Hudek, I have a housekeeping matter too, which is to ask you please to remember to keep your voice up and try and talk close
Yes.
to the microphone. People, including your own counsel, are finding it hard to hear you, I'm told. So,
Okay.
thank you. Now, returning to the topic we were discussing just before the luncheon adjournment, Ms. Hudek, Commissioner Bagoni was asking you about whether you, in your capacity as head of the CSI team, had seen the July 2018 audit at the time, and you told us that you hadn't, and we had that discussion about what trigger might be appropriately in place to ensure that someone in your position did get that, did receive that information. A question that flows from that, which I'd like to pursue with you, is you've told us that part of your role was a reporting up role to the executive leadership team and to the board about clinical safety issues. Is that right?
I reported only to the Chief Operating Officer
Yes.
/ Chief Nurse. My role as head of CSI was to provide reporting on behalf of CSI and the CSI team to the board or
Yes.
to the executive leadership team.
Via the Chief Operating Officer. Is that the case, or directly?
Most of the reporting will go through the Chief Operating Officer. Formalised reporting I would do with the clinical governance team in Bupa,
Yes.
and those reports would go to the board.
Okay. The question that I'd like you to consider is how you could fulfil those responsibilities appropriately and fully if you didn't get an audit report like this one, in this case, when it's, you know, the third or fourth in a string of poor outcomes. If they're not coming to you personally, how are you keeping abreast of trends that you need then to be reporting up the line?
At the time I was head of CSI, the monitoring of what was happening in care homes was done through a number of ways. One being mock audits, another being a high-level overview of the clinical indicators that were coming out of the care homes, things such as number of falls, pressure injuries, infections and so forth.
Yes.
That would be aggregated up, and if there are anomalies, they would be discussed. We would also have a lot of informal conversations through the operations leadership team
Yes.
meeting. And my expectation was that the Chief Operating Officer would be across the issues and disseminate that information with the executive leadership team.
So paragraph 30 of your statement, perhaps if we could go to that. Just make sure it's the same in your amended statement. It's on page 8 of the exhibit 1330, please. Sorry, I'm looking at the earlier version. The sentence starts, the mock audit would have been, perhaps it's on the next page. That's really weird. Sorry, Commissioners. It is paragraph 30. Yes, so do you see you say there, as set out in paragraph 26, the progress of any CIP, that's the improvement plan in response to the mock audit, is that right?
Yes, that's correct.
Progress of any CIP arising out of the mock audit would have been discussed at the operations leadership team meeting, which included the CAO, but I do not have a specific recollection of the discussion. If I could just unpack that.
Yes.
Were you a member of the operations leadership team?
Yes, I was.
Okay, so you don't recall any specific discussion of the July 2018 South Hobart
No.
audit? Okay. But you're saying, as I understand it, that you would expect that to have occurred based on your normal experience
Yes.
of the way things worked?
That's correct.
A request has been made of Bupa for the minutes of that those meetings. I take it they were minuted. Is that your experience?
Yes, that particular element of reviewing the CIPs was done on a separate Excel spreadsheet, which I can't recall whether or not that would normally have been included with the minutes.
Okay, so just so that the record is clear, the Commission has sought from Bupa any records of a discussion of the July 2018 South Hobart audit at the operations leadership team, and the response, or no such minutes have been provided to the Royal Commission. So my question for you is it possible in those circumstances that this wasn't discussed?
The time frame that it should have been discussed should have been around about October.
Yes.
Because what we discussed was the progress against the timeframes that those improvement plans were due to be completed. It may well be, and I'm only making an assumption here, that as the home had been sanctioned at that time, that perhaps that took precedence.
All right. Another aspect of the CSI team that I want to explore with you briefly is the evidence you give about cuts that were implemented to staff within the CSI team.
Yes.
Now, if I understand your statement, you're saying there was a restructure in 2017 which took effect from July 2018. Have I got that right, or am I misreading?
There was a restructure that occurred in November 17.
Yes.
And the second part of that restructure occurred in, from my recollection, July 18.
Okay, I don't want you to guess. Perhaps if we can go to paragraph 17 of your statement, please. Is that the restructure that we were just talking about a moment ago that you're referring to?
That was, as I could recall it.
And are those positions that are listed there ones that were removed?
They were the new positions.
I see. And so what was the net effect of the restructure? Was it a reduction in members of the team?
So in November 2017, obviously wasn't in that role then, but as I understand it, there were a number of clinical educators, the clinical education team in particular, was removed. I'm not sure if that was through redundancies or what occurred in that space, but there were a clinical educator allocated to each region and a clinical education manager.
Yes.
And that team was deleted, with the exception of one educator that remained in the CSI team as of when I took over the role.
And you may not be able to answer this because I understand it was before your time there, but are you able to tell the Commission what the rationale was for those changes?
No, I cannot.
Perhaps I'll put that another way. Do you know of anything which was put in its place that would achieve the same outcome of that clinical education role?
The clinical education consultant that I retained in the team, as I understand it, her role was to design and develop clinical education programs for our clinicians. and that was a move away from previously the clinical educators, as I understood it, who were allocated to each region, were allocated to deliver clinical education to the nurses in their region. That was to be managed by the homes, as I understood it, when those roles were removed.
I want to ask you a little bit about the introduction of BMOC2, Bupa Model of Care 2, and Project James. You were on a Project James committee.
A working group?
Working
Yes.
group, I'm sorry. Perhaps if tab 174 could please be brought up. And if we could go to page .0007, please. So we understand this to be the governance and team structure for Project James. Is that correct, Ms Hudek?
Yes, as a initially Ian Burge also sat in that team as well prior to him leaving as Director of Operations.
I see.
But this was obviously after the Project James working group.
So we see on the top row, underneath ANZ exec, we see that Maureen Berry was the sponsor of the project. Is that right?
Yes, that's correct.
And then under her in the green middle box, we see yourself and Ms Tierney from the CSI team.
I was representing as Regional Director from an operations perspective only.
I see.
Not as clinical service improvement.
And Ms Tierney, was she your predecessor in the CSI
Yes, she was.
team?
She was the she held the director role before it changed to head of.
Okay, so if we look on the right-hand side, the writing under the heading Working Group, and that's the working group you referred to a moment ago that you were a member of. Is that right?
Yes, that's
Yeah.
correct.
So the tasks there for the working group, I just want to ask you briefly about the first one: to seek feedback, consult where relevant, to gain relevant information on approach, process, risks and issues. The reference there to risks would encompass risks to clinical care as a result of the implementation of the project, would they?
I would expect that would be the purpose of that, yes.
And you, and perhaps more so Ms Tierney, would have been key people who were able to advise the
Yes.
project team about
I
that.
mainly gave advice from an operational perspective, but I did also provide advice from my view, from a clinical perspective.
And do we see that documented anywhere? Or would we be able to see it documented anywhere from your recollection of what happened?
I can't recall any minutes or actions being circulated as a result of these meetings.
Okay.
I'm not sure if there were. I simply can't recall.
Yes. So it seems to, from perhaps the naive perspective that I have of these things, it seems to be likely, to put it mildly, that a reduction in numbers of nurses and nursing hours could have a deleterious impact on clinical care in nursing homes. Would you accept that as a general proposition?
Yes, I would. Can I expand on that?
Please do.
So initially, the Bupa model of care that was initially implemented between, from memory, 2015 to 2017.
BMOC 1?
BMOC 1, you
Yes.
might refer to it. Yes, that was
Yes.
the original model of care.
Yes.
Made substantial investment into the business in terms of creating a preventative and proactive approach to care delivery for our residents, for Bupa's residents.
Yes.
My experience, I was General Manager at Bupa Wodonga when the pilot project rolled out for that, and there was a research project, as I believe was done by University of Tasmania, to collect evidence and demonstrate the benefits of having a proactive model in place. So it included employing GPs where possible, adding on clinical managers who would support the GPs in their role. It streamlined some of the processes initially for the care managers, and it streamlined the way that the leadership meetings happen, so quality of care, quality improvement and work health and safety and so forth were bundled into one meeting but done on a regular basis,
Yeah.
more regular than what had occurred before, and 6 weekly resident review meetings where certain elements of a resident's changing care needs could be captured and reviewed in a multidisciplinary approach much earlier. I felt I was quite passionate about that model,
Yes.
and from my experience in one home, I could see the benefits that provided the home. We weren't fortunate enough to have a GP employed. However, we, as a result of that, had created some really great relationships with local GPs to make sure they could still influence the way that model worked effectively. Anecdotally, I saw a decrease in the number of complaints, hospital admissions. The quality of care, I felt, improved. Medication incident reporting did go up, but I felt that was actually as a result of better reporting rather than actually the number of incidents going up.
Yes.
And we had better visibility of things like polypharmacy and so forth. So I was quite passionate about that. In 2017, approximately, and I'm guessing just from memory that it was perhaps about August, I was approached to join the Project James working group, which, as I understood it, was initially to look at reviewing the care manager hours and looking at what was the opportunity there. And now there was a survey that I believe was circulated from memory to nurses and care managers and general managers about how they viewed the model of care and the effectiveness of it. And there was feedback that came out as a result of that there was opportunities to improve the model of care and streamline some of the processes. It was felt that that there were certain tasks that care managers and clinical managers were both doing on top of each other. So there was a little bit of role ambiguity that had crept into the model. So there were doubling up of tasks. So there was opportunity to reduce the workload so that there wasn't those things happening in the homes and they could focus on one handover instead of 3, for example, on that day. So there was opportunity to look at improving that. When I was asked to join the working group, as I understand it, it was because of my experience with the model of care previously, as well as my operational experience to provide that advice. And the purpose, as I understood it, was, from memory, was to look at saving money for the business.
Yes, understand that. My question of you is, were you or anyone else with your level of clinical expertise raising concerns about the impact of the saving money initiative on clinical
Yes.
care?
Initially, with the clinical care manager element of it, I felt comfortable with that. And when it progressed to look at registered nurses, initially where we started with those registered nurses, I felt there was some opportunity with some of the homes. Not across the board, it wasn't a broad brush approach, but generally what should a model look like. But that was also taking into consideration that the CSI team had provided feedback that things such as leadership team meetings would be structured to reduce time. Resident review meetings didn't necessarily have to occur as regularly as 6 weeks. That a electronic clinical documentation system would be rolling out, which would create more efficiencies for our registered nurses. So with those things in mind, there were, I felt, opportunity for it to be done safely in some homes. That model was then continued. It was clear that it wasn't meeting the target that had been set for the SteerCo, and they continued to look at the staffing as a result. I did raise my concerns in the working group several times about the clinical implications if the model continued to trim staffing hours. I did at one point, I believe it was perhaps around about November 17, only going off memory, which isn't great. I did actually specifically request that my concerns be documented because I felt so strongly about it. There was a reference group of a number of general managers who were representing homes of different sizes, and there were some of those general managers with certain sized homes did voice their concerns about it as well. Eventually, it was I felt that it was a majority rules attempt, and this is what we had to do.
Yes.
And after being reviewed by Maureen Berry with her specific experience and background in the CSI space, along with her being the chief nurse and Petra Tierney in that role, advocating along with these other contingencies such as electronic clinical documentation systems, and there was also opportunity to revisit how the hours would be structured. There was opportunity for homes to put in exceptions so that if their footprint, for example, was going to be an issue, then you could put in an exception to not use the model. If registered nursing recruitment was challenging in a home, in a town, or skill mix was not ideal, you could put in an exception. And it was also built on the contingency that enrolled nurses in some of these cases would be quite difficult to have in a home based on their scope of practice because of the additional workload and clinical supervision that the registered nurse would be able to make.
Ms. Hudek, I understand all that. There was a debate and a discussion, but at the end of the day,
Yes.
the project was largely implemented, albeit with some exceptions, as we've heard, for example, at Bupa South Hobart.
Yes.
The project, as you've told us, was essentially about cost cutting and was implemented despite the concerns you and others raised about the effect on care.
Yes, it was.
Is the Commission to understand that there's a link between the cost cutting and the reduction of nursing positions and nursing hours and the extensive non-compliances that were identified at various Bupa homes that were the subject of
I think it's one of many factors.
What are the others?
Culture became problematic in Bupa, in that there was large, significant turnover of general managers and care managers. There was various restructures which made it difficult at times for people within the business to understand how to or who to report to and escalate up concerns that they might have had. Not having an electronic clinical documentation system has been a concern for some time. I'm not sure if that's in place now since I left, but it was certainly had been raised for many years, and there had been a team working on that to put something in place, as long with a medication electronic system, which I believe when I left was in the process of being rolled out across Bupa as well. Sorry.
Sorry, I was going to... Thank you. Ms Webb, you've been sitting there quietly, patiently. Could I ask you, in light of the evidence we're hearing about culture and the organisational concerns that have been raised by Ms Hudek, in hindsight, what could Bupa have done to better assess these organisational culture issues and monitor them so that they didn't become so problematic?
Look, I think that's a good question. I think that for me, the leadership in a care home is essential. I think they can lead the culture in the care home. A leader who sits behind the desk trying to lead a care home from there will inevitably have a culture that isn't accountable out on the floor. So I do think that in cases where perhaps we're slow to act, slow to respond, when it became evident that there was a culture in a care home that needed a better oversight. So I think there is a learning in that space that, to be on top of that, to understand it better and to have a clearer picture of the culture in the care homes.
Ms Hudek, is there anything you would like to add to that?
I certainly agree with Davida. I think one of the challenges that certainly I had visibility of coming into the head of CSI role, particularly after a couple of months in when I was attempting to get my feet on the ground, was the volume and the sheer size of the amount of turnover that we're seeing from general managers. We had a lot of vacancies, and not having that stability in care homes has always been a risk in a home. And general managers who are engaged with their workforce and engaged with their residents and relatives, in my experience, have always been much more successful homes as a result.
What's the role of the executive leadership in an organisation like Bupa to foster improved culture and the sort of loyalty that is needed to keep people in their positions and provide that stability? What are the lessons that the Commission can learn
I
about
think
that?
from my perspective, leadership is the role of an executive in any organisation is to inspire and motivate and engage their workforce. And that is about role modelling, that is about creating inspiration, it's about sharing a vision, understanding what the strategic direction is and telling a story and engaging your workforce with that in a way that wins their hearts and minds and bringing those teams on their journey for that.
Now, I want to ask you just a couple of questions about the post-sanctions period, which you've both dealt with in your statements and in other material. If tab 163 could please be brought up. This appears to be an email exchange between you, Ms Webb, and Dr Maggie Hirsch, who was the nurse advisor that was appointed to assist with responding to the sanctions that were imposed on Bupa South Hobart. And if we start halfway down, we see that Dr Hirsch was writing to yourself and Mandy. That appears to be Amanda Woodorth. She was the General Manager at Bupa South Hobart, is that right? She's,
Correct.
I think, recently left that role. And we can see that she wrote, Dear Mandy and Davida, as Administrator and Advisor, John, that would appear to be John Engler, and I have looked at the proposed staffing numbers carefully and strongly recommend the current staffing cover remains the same without modification for the next 3 months for the following reasons. And then if we skip over 1, you'll see point 2. This period of transitioning from a sanctioned environment is particularly important. We know other homes who've quickly gone back into sanctions when the home could not maintain the level of care and support for residents. The staffing changes proposed are likely to significantly impact on the increased needs for residents living on level 1 of the lodge. There is a need to have a minimum of 3 staff on both shifts. The industrial implications of the staff changes are likely to affect the staff morale, and much work has been done to create a positive culture. And it goes on. Do you recall getting this email, Ms Webb?
I do.
What's the reference to the staffing changes proposed in point 2 there? Do you know?
I believe it was, from recollection, I believe it was regarding the Project James model still.
Yes.
We had put a lot of hours back into the care home, and I understand that that request was to say, can we leave those hours, the additional hours that we put in to manage the sanction, and to assist on the care home to leave those in place for a period of 3 months, obviously, from this email.
Yeah, so, okay, was someone proposing that those additional hours be stripped back? Is that what we're to understand from this email?
I'm not quite sure. I can't recall that, but I think it was because we had added in additional,
yes.
And perhaps there was conversation about when do we change that to be brought back in line with the occupancy. So Maggie clearly was saying that it would be good to leave it in there for another 3 months at least.
The reason I'm raising it with you is it seems to suggest that there is this almost irresistible desire to reduce staffing numbers at Bupa South Hobart as soon as an immediate problem has been overcome. In this case, the sanctions, then we see re-accreditation, and then apparently a desire to reduce staffing numbers again. Am I missing the point, or am I... is that correct?
No, look, I can see how you can think that through this, but there was, with the roster changes that were made back in 2017, where I was a regional director and the role was to actually implement that roster, coming into the head of operations, particularly, and then that role with the roster, I recall a time when I myself went into Bupa Hobart, looked at their roster for some reason, when I think the admin might have brought it to me to ask me if they could have another staff member. I looked at that and thought, this needs to have additional staff because of the layout of the building. So I sought approval for that from the Chief Operating Officer at the time. I can't remember, I think it was Caro Cooper, who absolutely approved that. I then asked Ms Cooper if we could look at the roster in its entirety and try to come up with a science behind the roster in terms of, developing a roster that we know has got some basis behind it, rather than just trying to keep plucking numbers out and putting numbers in a place.
And is that the 2.5 hours per resident
Yes.
per care roster?
For direct care only, yes.
Yes. And we understand that was based on some industry benchmarking that had been done by Bupa, is that right?
Some industry benchmarking, but I personally felt that that wasn't going to be enough because we continue to talk about benchmarking. So I was trying to find a way that we could incorporate the ACFI tool into determining how that would look. My theory behind it was that the ACFI tool was a tool that was based on care needs of a resident and assessment needs, and that if we worked backwards, we should be able to find out what the Medicare government concept was behind what should be delivered.
Do you accept that there's a danger in trying to apply a one-size-fits-all number of hours of care across an organisation as large as Bupa?
I do, and so because we have different layouts of the buildings,
Yes.
And for that reason, Ms Cooper came up with what she called a warranted variation, which was a way of managing that. So if a care home, for example, like South Hobart has 3 buildings, they had a warranted variation because that model would need to be adjusted to fit that building.
Just a clarification of the terminology. The evidence from Ms Cooper is that Project James was paused in September 2018. This is now 2019. This is a different rostering concept, isn't it? The 2019 roster that Ms Cooper developed, is that right?
Correct. Towards the end of probably around September, I guess, would be it. Just trying to think of the dates, but correct in that we went back in and we had a look at it to try and get some validity behind it.
I've been asked to ask you to step back a little bit from the microphone if you
sorry.
don't mind. It's just that there's interference.
Sorry.
We can't win with the microphones. If I could just ask finally both of you, we've, I think, benefited greatly from the observations that you've been able to make about the experience, particularly at Bupa South Hobart. Ms Hudek, you firstly, is there any other message that you have for the commissioners, the work that they are doing and the recommendations they're considering making?
Look, I believe really strongly in making sure that all the information is gathered, and one of the things that I did do in my role before I left Bupa was to design a new risk profiling tool so that it didn't just identify current risk but was able to predict emerging risk by joining all of those dots, such as culture, morale, engagement from both staff and consumers. It looked at staff turnover, vacancy rates in terms of staff vacancy rates, not just clinical indicators as a standalone tool. It was also, excuse me, it was also important to consider previous history as well. There was a fairly subjective element to that tool also that involved a roundtable conversation as to what were some of the other things or perhaps themes that we're seeing in homes, external to the home complaints, numbers of those, who they were being escalated to. It was a much more broader range of data, I guess, that we considered as a result, and the hope was that continued to identify emerging risks much earlier on, and that was purely from experience of the Vanessa Lane, the clinical governance director, as well as excuse me, as well as my own experience from an operational perspective, sitting back and thinking about as a regional director, what do I look for in a home that might present some early warning signs, such as recent change in leadership and so forth. So that's probably one of the biggest learnings that I certainly took away, the importance of looking at all of the data that we have access to and not just individual components to that.
Thank you. And Ms Webb, you're now in a new role. You've got a significant responsibility in terms of a number of homes. What have you learnt from your experience at Bupa that you can share with the Commission that you're using in your new role?
I've learnt so much from this actually. To Linda's point, with the early warning system tool that Linda started working on and developing, I've taken that away, risk assessment tool on every care home, incorporating things such as staff turnover, vacancies in leadership teams, feedback that we're getting from customers. The other thing on it I took away from it is that we never really had an itemised structure for a regional director or operations manager when they go into a home. So there was nothing to say you need to look at this, this or this. Towards the end of my time at Bupa, they had developed and was developing a care home assessment tool that for the operations managers to use in their care homes. So I think that's critical in terms of making sure you follow, because that way you're checking up, you're talking to customers, talking to residents, talking to staff, reviewing files, progress notes, and that sort of thing, so to capture those things a lot quicker.
They're the questions that I have, Commissioners, for the two witnesses.
I think I've only got really one broad question to ask you. Obviously, operations and clinical, when you put the two together, make up pretty much the whole of the operations or the whole of the enterprise. And the smaller the operation, the more likely that those two elements will not be separated. The bigger the outfit, the more likely that they will be separated. And the bigger it gets, the more likely the two won't be talking to each other. And yet they are two aspects of an integral whole. Operations presumably include things like staffing, and care obviously includes staffing. So that's a simple example of the two. Have you got anything to say about how in large-ish organisations like Bupa, but not necessarily Bupa, might ensure that as those two functions of the same thing get separated, they nonetheless keep talking to each other?
Thank you, Commissioner. I completely agree. And I think that one way, I suppose, would be with the assessment tool that's in place is making sure that the operational components are linked in with that as well, because you've got to have the communication in order for all that to be together. I think also perhaps thinking about the role definitions for the clinical people in the care homes and the operation people in the care homes, in terms of bringing those roles closer together so that the boundaries get a bit further blurred, so people are working across both and incorporating both together. As
I was listening to Davida then, I was reflecting back on the structure that Bupa had in 2016 and previously, prior to that, where there was a managing director and a director of operations and a director of CSI. At that point in time, I didn't have close insight as to how those relationships worked, but my reflections would certainly be that when I look back to that structure and how the director of operations and the director of CSI worked together, we didn't appear to have some of these issues then. They worked closely together. They were both in the head office, but at the same time, the director of operations had intimate knowledge of every care home in Bupa. And an element of that, I think, was lost when he left the business. So I think there needs to be some consideration about how do we capture that that experience and knowledge in a way that we don't lose it. So fundamentally, I think part of it is about making sure that the infrastructure is there to support from a reporting system so that we have visibility of that is one thing. But certainly creating those collaborative relationships are key to, I think, any good organisation small or large, having teams that actively collaborate well together, notwithstanding that last year, from when I came into the role, we were already seeing compliance issues to a degree that Bupa had never seen before. So the business was at that, in all intensive purposes, in chaos from that point onwards. So the structure did not support that, along with all of the ongoing restructures that continue to occur as a result.
Thank you. Thank you to each of you. Your evidence has been helpful. We're grateful for what you've said, and you're free to go. Thank you.
Thank you.
I think
we need 5 minutes, I think, to establish a video link with the next witness.
All right, so you'd like us to vacate for a moment or two? All right, we'll adjourn temporarily.
stand.
Thank you, Commissioners. Should just check, Ms Wiles, that you can hear me clearly.
I can, thank you.
Okay, there's a little bit of a delay at our end. Are you also getting a little bit of delay from me?
I can't see you speaking, so it's difficult to gauge that.
Okay, all right. Anyway, we have contact, so I think we can press on. Now, Ms Wiles, can you please, for the purposes of the transcript here, state your full name?
Tiffany Clara Wiles,
And that's Clara, C-L-A-R-A.
correct?
And you have made a witness statement for the Royal Commission dated the 8th of October 2019.
Yes,
And for the purposes of our transcript, the code for that is WIT.0499.0001.0001. Have you had an opportunity to read through a copy of your statement before giving evidence this afternoon?
I have.
And is there anything in your statement that you would like to change?
No.
Just before I ask you the next question, was the witness sworn? I'm not sure if that occurred.
No, that has not yet occurred.
No. Do we?
We should.
We should.
Yes.
Yes. My apologies for starting without it being done. Do we have that capacity, Mr. Associate? Yes.
We do.
There should be somebody at the other end.
I solemnly and sincerely
I solemnly and sincerely
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
My apologies, Ms. Wiles, for not allowing that to occur before I started asking you questions. I think we'd reached a point where I asked you if the contents of your statement were true and correct,
Yes?
and they are.
Yes. Thank you. Yes.
I tendered the statement of Tiffany Wiles dated the 8th of October 2019, Commissioners.
That will be Exhibit 1331.
Ms Wiles, you are the director of a company called Key 2 Care Proprietary Limited,
Yes?
and Key 2 Care Proprietary Limited was established in 2013, is that right?
That's right.
And the company provides support and management services to the aged care industry.
Yes?
And I take it that part of that is what might be described as preemptive support and management services. That is before there's any question of sanctions having been imposed on a care home, is that right?
Yes.
And
There is. We do that.
yes, and in addition,
Yes.
you're available to perform the role of advisor under the Aged Care Act for
Yes.
homes that have been sanctioned. Is that right?
Yes.
And is the company also able to perform the role of an administrator under the Aged Care Act for homes that have been sanctioned?
We don't have the capacity to do that at this point in time.
I see. Just out of interest, they're obviously quite different roles, with an administrator being more concerned with corporate governance and business operations, aspects of an approved provider's service provision. From your perspective, for the company to be able to provide that sort of service and be appointed as an administrator, what sort of expertise would you be looking for to be able to do that?
I would be looking to outsource somebody who's had experience in that role, firstly.
Yes.
Somebody who has a a higher level skill, certainly a higher level skill set than I have capacity for, and definite experience in governance and board level advice, I suppose.
Yeah, so when you say higher level skill, you don't mean higher level clinical skills, you mean different skills such as those
skills.
Those involved in governance.
Well, that's right.
I see. Thank you.
Yeah, no, not necessarily higher level clinical skills. I think there's a difference, certainly a different role as administrator.
Yes.
Clinical skills wouldn't go astray, obviously, but certainly it's not something that I have the capacity to do at the moment.
All right. Now, I neglected to ask you, but you are a registered nurse.
Correct?
And you also have postgraduate qualifications in gerontology.
Yes.
Where did you obtain your postgraduate qualifications?
It's a hospital-based qualification in. It was the Woden Valley Hospital in Canberra, which is now the Royal Canberra Hospital.
I see. Excuse my ignorance, but they're postgraduate qualifications in nursing, is that right?
It's in gerontology is a specialty in nursing around care of the elderly.
Yes, but it is a specialty within the nursing area. Yes, I understand.
Yes.
Prior to performing the role as advisor at Bupa South Hobart, you had one previous experience of being an advisor at a home in 2018, in a place called Jimbalunga, if I'm correctly pronouncing that.
That's right.
And over what duration were you appointed in that capacity?
For their timetable for improvement, over a 6-month period.
Right. Now, I want to ask you some questions about the time that you spent at South Hobart. So you were appointed advisor there, nurse advisor, on the 1st of November 2018?
Yes.
And that was, what, about a week or so after the sanctions had been imposed on Bupa?
I believe so. I was approached by George I was approached by Bupa on the recommendation of George Surahev, who was the contact person in Doha during my period of support to Jimbalunga. He then transferred, I understand, to work for Bupa.
And Doha is, of course, the Commonwealth Department of Health. Is that right?
Yes.
Yes, okay. Now, if I can ask you about some of the observations that you have included in your witness statement about Bupa South Hobart when you started working there. One of the issues you identify, and this is page 6 of your statement if it helps, so you're asked about barriers that you encountered while acting as an advisor at Bupa South Hobart, and you refer in a couple of places. Firstly, it's actually page 5, paragraph 15.
Yes.
You talk about a disengaged local Bupa general manager, who we understand to be Mr. Neil at that time, is that right?
Correct.
And you make the point that he, at that time, had already resigned, is that right?
Yes.
But was working
my understanding.
Working out quite a lengthy period of notice.
That's right.
Some 2 months, I think, as it turned out. What was the difficulty there that you encountered?
I had felt that David had actually, disengaged. Once you make a decision to leave a position, it's very difficult to work out such a lengthy notice period and remain engaged because you look into the future. So I think it was a very difficult position for him to be in.
All right. You make a broader point on the following page, as I understand it, in the first main dot point. It's about a third of the way down the page. If you can see that, you say there was a lack of proper on-site management and leadership at Bupa South Hobart. Is that a broader point than just the one you've raised about the disengagement of Mr. Neil personally?
Yes, I think that there was also a disconnection between the area support strategies and people and Mr. Neil, and that didn't have any coherence really around a strategic approach to resolution.
I just want to ask you an aspect of the audit report that led to the sanctions. I'm not sure if you have access there to all of the documents that we can display it. So it's tab 85. And what I'm asking you to look at here, Ms. Wiles, is the evidence record of the re-accreditation audit that was conducted in October 2018 by the Quality Agency. We know that Bupa South Hobart did not meet 32 of the 44 expected outcomes. You understand that?
Yes.
One of the outcomes it did meet, though, was planning and leadership. If you have a look at the third page of the document, which is .2086. Do you see that? There's outcome 1.5 is planning and leadership.
Yes.
And the statement there, very brief as it is, the home meets the expected outcome, and then evidence considered, the team was not presented with any evidence indicating that the expected outcome is not met. Did you have cause to consider what appears to be perhaps a conflict between your observations about leadership and the outcome of the Quality Agency? And can you help us reconcile the two?
I think that the agency are looking at a snapshot in time and presented with evidence that they have in front of them. And my statement is based on information over time. Yes. And my total experience.
All right. And beyond that, you'd probably suggest we ask them how they came to that conclusion.
Absolutely.
Now, another matter you raise in the course of your statement was concerns that were raised with you by families. And I just want to ask you about that. Firstly, what was the nature of the concerns that were raised with you?
There were multiple concerns raised, and even to the point after I had been at the initial residence meeting, I was overwhelmed with contact from families, and so I set up a situation where I would allow each family to have some time to spend with me to voice their concerns. A lot of issues around food, pain management, general basic cares, some skincare issues, beg your pardon, I can't remember specifically all of the things, but everything that was discussed was documented through the Bupa's quality system, their feedback mechanisms where I documented them, made recommendations and put them to Bupa for entering into their risk management.
Sure. I'm not so much
program.
Concerned to ask you about the detail of what was raised with you. I'm more interested in a broader question, which is whether that experience of being apparently inundated by requests from families and concerns being raised with you, whether that told you something about the culture of the organisation.
Absolutely. I think that people had raised issues to local management and they hadn't been heard, or there wasn't a resolution achieved that they were satisfied with. And they still felt that their relatives were at risk, I suppose.
And from your perspective and based on your experience, what would you identify as the hallmarks of good practice of complaints and concerns in an aged care home? What would you be looking for?
I'm sorry, can you repeat your question?
Now, I'm asking you a broader question based on your experience at Bupa South Hobart and based on your experience generally of the aged care industry. What are the hallmarks of good practice in relation to resident and family complaints and concerns handling by an aged care facility?
Oh, certainly being listened to, having an avenue, a structure, a forum to be able to be heard firstly, to have some structure around that so that they have a process, even if it's a step-by-step process where there's full disclosure as well, and that families are advised of any resolution or changes, particularly in response to their initial complaint. Or compliment.
Yes. Feedback, if we can use a neutral term, perhaps.
Yes, thank you.
Right.
Yes.
Now, at paragraph 17 of your statement, you note that a review of staffing was conducted on your initial arrival at Bupa South Hobart. Do you see that?
Yes.
What did that review of staffing involve? How did you do it?
It was actually in collaboration with the administrator. Anchor Excellence and Key to Care work very closely together.
Yes.
And we looked at the number of staff, the location, the difficult location of the site, being 3 buildings over multiple floors, and that's just the logistics of that makes staffing levels, the need for staffing higher, I thought.
Yes.
But there was a rationalisation of staffing as well, particularly around the clinical care managers. There was a rationalising of, based on the number of residents in the home, they decided that 2 care managers would be sufficient.
Rather...
my observation is 3 buildings with 2 care managers means that there's going to be a deficit somewhere.
And as we have seen, it's not just 3 buildings, but the buildings have several floors and lots of corners, don't they? It's not an easy place to get around. Is that relevant from a staffing point of view?
Look, I think it is. As a visitor to the site, it was actually very difficult to navigate the site, and I think for residents, if you've got staff allocated to one building and they're attending to residents on one floor, they can't leave that floor to attend residents on another floor or anybody who's calling somewhere else. So it does make it very, very difficult.
And what was the outcome of your review that you conducted together with Anchor Excellence? What did it lead to?
There was an increasing in staff hours. They'd actually put in an additional 35 hours a day.
Yes.
Which was very responsive. The challenge with it was, though, having the staff to fill those hours was, I don't think that they ever had a day that those additional hours were filled. So even they put a strategy in to remedy, but it wasn't. It was, it was almost impossible to get the number of hours filled.
Right. And you also make a reference to the training of the staff, the inadequacies of training. Can you expand on that? What was the problem there that you encountered?
Look, I think that there were, we had offered some behaviour management training and customer support training, specifically during our tenure. The challenge was releasing staff to actually attend the training. There seemed to be a priority to provide care, obviously, than to allow people to come to training. It was actually quite, the behaviour management training was well attended, the customer service training not so. The challenge of releasing people over a difficult site with multi-levels and multiple would be a priority. I thought that the care was the priority over and above the training because of not being able to release people.
Understand. Paragraph 21, you're asked to identify what you consider to be the key contributing factors that led to the safety and quality issues with care at Bupa South Hobart. You've already talked about a number of these, but I want to ask you about the last dot point in paragraph 21.
Yes.
In quotes, you've got profits before people, unquote.
Yes.
What are you seeking to convey to the Royal Commission there?
I think that I wanted to say that the way I can only compare it to my own ethics.
Yes.
Every interaction that I go into needs to be a win-win interaction. If it's a win for you and not for me, it's a no deal. And if it's a win for me and not for you, then it's a no deal. There has to be a shared goal, I think. But I felt that with Bupa South Hobart, there was an interest in cutting costs rather than caring for people. That's a very broad statement, obviously, but my general feeling was that, the financial KPIs were very important beyond the care KPIs.
And are you making that observation about the period that led up to the sanctions being imposed, or are you talking about the period when you were there between November and February of 2019?
I can only comment on the time that I was there. What happened prior to that is really speculation on my behalf.
Do you think that there was a proper and thorough understanding of the nature of the deficiencies that you found on the part of Bupa, the Bupa senior managers that you dealt with?
No, I don't think so. I think we had made a lot of recommendations and suggestions, and of course as advisors, they're not obliged to take our advice.
Yes.
So it's up to them to make a decision. I know that some of the things that we did suggest have been now embedded into their systems, which is a good thing. I'm not sure if I've answered your question. Do you need to ask me?
No, thank you. Now, the final matter I want to ask you about is the circumstances of the termination of your appointment. That occurred on the 11th of February 2019, so some 3 months after you were appointed, a little over 3 months, is that right?
Yes.
Was it originally envisaged by you that the appointment would run for longer than the 3 months?
Yes, a 6-month period for the duration of the timetable for improvement.
Now,
I actually had a contract for that.
Yes, for the sanctions period.
Yes.
You say at paragraph 19 of your statement that the services of Key 2 Care were terminated when you were contacted by Ms. Davida Webb of Bupa Management, and
yes.
You say that you were not told why and no complaints or issues had been raised about the services, is that right?
That's correct.
Ms Webb has dealt with this issue in a witness statement that she's provided that is now part of the evidence before the Royal Commission. And if I can summarise what she says about that, she says that your contract was terminated because of your poor performance, and that she'd been told by others who she identifies that you were often absent from the site and unable to be contacted. Would you like to respond to that evidence that Ms Webb has given Ms Wiles?
Absolutely. Our contract was only ever for 5 days a fortnight, and we actually attended the site, either I or a representative attended the site for a lot more than that. So it could be a misunderstanding of the terms of our contract, firstly.
Yes.
And secondly, all emails and telephone calls were responded to within a business day, on the same business day.
Commissioners, they're the questions that I have for Ms Wiles.
Yes, thank you. Ms Wiles, thank you very much for giving evidence, albeit remotely, and your excuse from further attendance. Thank you.
I appreciate the fact that you've been able to give me the remote access related to my family circumstances. Thank you.
Thank you.
Thank you, Ms Wiles. I think we can end the link. I think it's happened.
Thank you.
The final witnesses for the day, Commissioners, are a panel of 3 from Anchor Excellence. I call John Engler and Cynthia Payne and Dr Maggie Hirsch.
Commissioners, while the witnesses are coming up,
Yes.
may it please the Commission, my name is Lloyd. I appear for the 3 witnesses witness bench instructed by Spark Helmore. I understand that leave has already been granted.
Yes, thank you, Mr Lloyd. Do feel free to sit down, make yourselves comfortable.
Thank you, Commissioners. If I can start with you, Ms Payne, I'll ask you please to state your full name for the transcript.
Cynthia Ramona Brenda Payne.
And Ms Payne, you have made a witness statement for the Royal Commission dated the 6th of October 2019, is that right?
That's correct.
And it has the code WIT.0467.0001.001. Have you had an opportunity to read through your statement before giving evidence this afternoon?
Yes, I have.
And is there anything you'd like to change in your statement?
No.
And are its contents true and correct?
Yes, that's correct.
Tender the statement of Cynthia Payne dated the 6th of October 2019, Commissioners.
That's Exhibit 13-32.
Mr Engler, if I could turn to you, please, and ask you to state your full name.
John Patrick
Thank you. And Mr Engler, you too have made a witness statement for the Royal Commission bearing the same date, the 6th of October 2019.
That's correct.
And the code for your statement is WIT.0468.0001.001.
That's correct.
You have had an opportunity to read through that statement, have you, before giving evidence?
I have.
Anything you'd like to change?
No, there's nothing.
And the contents are true and correct?
True and correct.
Tender the statement of John Engler dated the 6th of October 2019.
That's Exhibit 1333.
And lastly, Dr Hirsch, I hope I'm pronouncing
You
that
are.
correctly.
Hirsch, yes.
Sigh of relief. You have made a witness statement dated the 4th of October 2019
That's
for the
correct.
Commission.
Yes.
And it bears the code WIT.0466.0001.001.
Correct.
And there are 3 corrections that you have identified for us through your lawyers that you'd like to make to the witness statement, is that right?
That's correct, yes.
All minor matters, but important nonetheless. The first is in paragraph 5. Is that right?
That's correct.
And there are actually 2 changes in that paragraph. Firstly, you'd like it noted that your PhD was awarded in the year 2000, is that
Correct.
right? So if at the end of the first sentence after Newcastle we were to write in 2000, would that meet that
Correct.
concern?
Yes, please.
And the second change is in the very last line, 1977 should in fact be 1988.
That's correct.
The second change that you would ask us to make is in paragraph 10 on the second page of the statement.
Yes.
And it's the time during which you have provided support for the Bupa home in Bendigo that you would like to amend.
That's correct.
And would your concern be met if we deleted the words 4 weeks in brackets after Bupa Bendigo and inserted 9th of September 1919 to the 20th of October 1919?
Yes, that's correct.
Okay. The next matter is actually not one that you've identified for us, but I think it may need amending. I'm sorry, it is one of yours. It's paragraph 42 on page 8.
Correct.
In the first line, there's a reference to the behaviours of dementia patients. You'd like us to delete the word patients and insert before the word dementia people living with. Is that right?
It should be referred to as people living with dementia rather than dementia patients.
Yes, so we
Yes.
delete patients and it will now read behaviours of people living with dementia.
Correct.
Comma.
Thank you.
Thank you. I think there are also a couple of dates which have accidentally been incorrectly typed. Could you have a look at paragraph 43 on page 9? That date 9 April 2018 I think should be 2019.
That's correct, yes.
And equally on paragraph 53, same issue. I attended at Bupa South Hobart nearly every week from 9th of April 2018 should be 2019.
That's correct.
And with those changes, are the contents of your statement true and correct?
Yes, they are.
I tender the statement of Dr Hirsch.
It's Exhibit 1334.
Now, just so that the Commissioners understand the respective roles that you had in relation to Bupa South Hobart, you all come into the picture post the sanctions period, if I can put it that way.
Correct.
None of you had any role before that time. No. I can't let the transcript record that you've all shook your heads at that point. And your appointment, Ms Payne, was as administrator, and it was from the date of 6th of November 18.
That's correct.
And you performed that role at Bupa South Hobart until you were appointed the National Administrator of Bupa in March 2019.
Yeah, that's correct.
All right. And just so that's understood, when I say appointed to the position of Administrator, it's an appointment under the Aged Care Act, isn't it?
Yes, it's directly connected to a sanctions notice issued by the Department of Health.
Yes, so the sanctions notice, as is commonly the case, informed Bupa that its it was required as a condition of staying open during the sanctions period that it appoint an administrator and an advisor.
Yes, that's correct.
And the administrator role is one that is focused on corporate governance and the business operations of the provider. Is that right?
That's correct.
And are those matters of which you'd had experience prior to the appointment on the 6th of November?
Specifically as an administrator, no, but in the general course of my working career.
And can you just summarise what that experience was relevantly for this role?
15 years having operated as the Chief Executive Officer for a New South Wales-based aged care provider, Summit Care.
Yes.
And prior to that, roles as leading aged care services, such as being the Director of Care, Village Manager, working as a registered nurse, and having been involved in the peak industry body.
Now, you were selected for this role by Bupa, is that right?
That's correct.
And it's the case, isn't it, that there's no list of people who are eligible to be administrators that's maintained by the Department of Health?
Yeah, my recollection is that there used to be a panel list,
yes.
And at some earlier point there was a decision to not maintain the panel.
Without going into the pros and cons of that decision, do you think that having a list would be a good idea from the point of view of the industry?
Yes, I do. I think it is.
Why is that?
Because I think that there is a mechanism in which the skills and the qualifications of the individuals can actually be screened, they can be made public, and they can be available to the approved provider. There is I think I make a point in my statement, there is a short period of time in which the Department of Health expects the approved provider to be able to make those appointments. And
it's generally within a week, isn't it, at most?
It's a very quick turnaround. I think it's technically 2 weeks.
Yes.
But obviously they then need to be able to identify the requisite person that might fit their requirements, and a list obviously would help with that.
Do you know whether there is any vetting by the Department of Health of the identified administrator by a provider? In other words, when the provider says, we want to appoint Cynthia Payne, is there any process by which the department vets that appointment, or is it just...
I'm not included in that process,
No.
But I believe that when the approved provider makes a nomination to the Department of Health, the Department of Health accepts that nomination. So I believe that they do need to satisfy the Department of Health, but I do not believe that that is specified anywhere.
Okay. Mr Engler, if I can turn to you, because you took over the role that we've been discussing with Ms Payne when she became the National Administrator, is that right?
That's correct, yes.
And how did that appointment come about? In other words, it wasn't done just in-house at Anchor Excellence, was it? It was a separate appointment that was made by Bupa?
Yes, indeed, and I'd previously been appointed as an administrator in another standalone facility, not a Bupa facility,
yes.
in another territory in Australia, and had performed that role well. I became available then to be nominated as a possible administrator to replace Cynthia substantively on the 20th of March when she took over the national role.
Yes. And do you have anything to add to the observations that Ms Payne made about the notion of some register or a list of approved administrators or approved people able to be appointed as administrators?
Most certainly. I think that we've been firm in our understanding, both as an organisation and as an industry, of the need to really bed down and secure the skills, experience and qualifications that would be needed for administrators and advisors to be effective and monitored, evaluated, reviewed and understood more broadly as part of remediation or any particularly sanction activity, but in terms of improvement and quality in aged care generally.
And finally, for the moment, Dr Hirsch, you were appointed an advisor to
Yes.
Bupa South Hobart with effect from the 9th of April 2019.
That's correct.
Were you in the hearing room when we heard from Tiffany Wiles, the previous
Yes,
witness?
I was.
So you actually replaced her, did you not, as the advisor?
I think there was a period where I think it wasn't directly straight after. I think Carla Beheron, which was did a period before that. I'm not completely clear about the history or the logistics involved behind that. I can only verify my start date.
Okay,
so
I understand.
Yeah, because we work as a company, which is also I think somewhat unique. There's a lot of collaboration that happens as a result of that, and handover as well.
In a situation where there's been an advisor in place and you come in either immediately after or shortly after they finish, do you think it would be beneficial to have some handover type discussion? I'm assuming there wasn't one here, or was there?
Well, as I said, we work very collaboratively. So John was already in place in terms of being administrator. So I could get a lot of information through our own internal process. But absolutely, having handover is really essential, and getting all the correct documents on time to be able to help prepare you for the role as and when they come through from the organisation itself is in fact essential.
Do you mind if I explain that in the process of Bupa making the decision to cease the contract with Key to Care, there was a request made of me of whether or not there was an ability to provide an advisor service. In between, there was an internal incumbent, Tina Doyle, who is part of the clinical services team, that was actually implemented, I think, for about 3 weeks. And on the 28th of February, Carla Beheron was with John and I as part of an orientation and handover. Subsequent to that, a sanction notice was issued to Bupa, which related to the national appointment. So there were, I guess, 2 streams that occurred in a short period of time.
Okay. Mr. Engler, if you could just be careful not to get too close to the microphone because it leads to feedback. I'm sorry to have to raise that with you, but that's a problem. I want to ask you some general questions because one of the focuses of this week's hearing is on governance within aged care providers and what the commissioners can learn from the evidence they're hearing and what sort of recommendations might potentially be made that will improve governance within the aged care sector. So perhaps if I could start with you, Ms Payne, given that you can draw on not only your experience generally, but the experience you've had at Bupa South Hobart and then more recently as National Administrator, if you could identify some key areas that you think need to be improved in relation to governance in the aged care sector, what would they be?
So if I start at the global level of the standard itself, I would say to you that the standard at the moment has quite an input focus.
Standard 8, are you talking
Standard
about?
8.
We might bring that up on the screen because I think it will help us. It's in the documents already tendered tender bundle, and it's document 2.2, I think. If you just bear with us while that's brought up on the screen, Ms Payne. About to be told if I'm right about that, I think.
Can't see anything yet.
Oh, I've got my own bucket over there. Thank you.
Sorry, Commissioners, we're just sorting that out. That's it. Yes, thank you. And if we could go to Standard 8, which is on dot... Yes, thank you. That's the Standard 8 organisational governance that you're referring to, Ms Payne. Thank you.
That is correct.
We'll just get that right-hand side of the page blown up to assist with your reading. of it, perhaps all the way down to the bottom of the page, please. Thank you very much. So we can see, as with all of these standards, divided into a consumer outcome, an organisation statement, and the various specific requirements that are imposed by the standard. What do you draw our specific attention to, Ms Payne?
So if I start by looking at the organisational statement,
Yes.
the organisation's governing body is accountable. What I would point to the Commission is we don't actually talk about performance. I think that's a key word that's actually missing.
Yes.
And when we move down to the requirements in themselves are all very important, but they don't necessarily speak to an organisational context from my perspective, a small organisation right through to a large organisation. So if I reflect on the conversations that the Commission has heard so far,
Yes.
we've talked about some really key elements that I actually touch on in my submission around segregation of duties as one element, clinical governance obviously is another element, consumer engagement. Now if we look at 8.3a, consumers are engaged in the development and delivery and evaluation of care and services and are supported in that engagement. That doesn't necessarily connect to the organisational context. There's a piece of ambiguity that I think the new standards, which I must say, Mr Rosen, it is very positive that we have a governance standard.
Yes.
But my point is, I think that where it's at the moment, it's bedding down in the system. So I would say that the Aged Care Quality and Safety Commission is working through how it is assessing those, and I think there will be a learning cycle since the implementation in July as we move forward to better understand what this means in a broad context. So if I can just speak specifically to something that's very important is data and knowledge and the measurement component. Measurement is broader than an internal review. I think the term used this morning was a mock audit, and there are indicators, clinical indicators, other business indicators, and a robust system, from my perspective, needs lead indicators, lag indicators, quantitative measures and qualitative measures. Now at the moment, if I look at that organisational governance standard, the connection of performance and measurement in terms of the organisation, that's not really apparent.
Can I just ask you about 8.3a, please, Ms Payne? This notion of consumers being engaged in development, delivery and evaluation of care and services, is there a place, from your point of view, in a governance standard that goes beyond that and requires a provider to engage in some form of consultation with families and residents, for example, when implementing a significant change? Would you see that as being a constructive requirement to impose?
I would say to you that that is best practice, that
Yes.
you would want to include in the process. This is for the elders living in an aged care home. It is their home. And so the first priority obviously is to the elder, and I do say I prefer that term to consumer, and then the representative is a separate matter. What I'm very happy about in these new standards is that they are consumer facing in the way that they are, first and foremost, and I think that is quite a challenge for every aged care organisation as it's adjusting itself to the new standards. There has been in the past, in my view, a more of an emphasis towards the representative voice, and that could be the family member, it could be the nominated decision maker, but actually what that is saying is that we are engaging elders and their representatives in the development and delivery, and the previous standards did not require that.
Mr Engler, can I ask you a slightly different question by focusing on 8.3d, which we see on the right-hand side of the screen? effective risk management systems and practices, including but not limited to, and then they're set out, managing high impact or high prevalence risks, identifying and responding to abuse and neglect, supporting consumers to live the best life they can. So under the standard, an organisation is required to demonstrate those matters. Is that an important aspect of good governance from your perspective, and why, if it is?
Most certainly, and I hope the volume's okay, Mr. Rosen. Yeah, most certainly. And I must say, in the case of Bupa, their own risk-man system, which identifies partly feedback, is a standard process for being able to identify risks and how they would be dealt with. For example, in their feedback system, though, it talks about a complaint, a compliment or a recommendation. We would go further using this Standard 8 organisational governance, which has been enhanced, to say you can actually do that earlier. You can actively seek a process of early engagement with residents to make sure that they're very involved, whether it's the resident, the elder or their representative, particularly where there's capacity that's been impacted, so the representative is in effect the voice of the elder. So to Bupa's credit, it already had a baseline it's called risk management system, that identified some of those things. Our take on it would be, and certainly I've got a couple of examples, we would say that could be enhanced or applied even further. So, and it might be more applicable to some of the other elements of Standard 8. But for example, when we talk about engagement of residents in decisions that affect them, we, for example, as part of our broader administrator advisor role, and certainly with Dr Harsh's assistance, set up a resident committee, engage residents, for example, in the interview of new staff, suggested that residents, if they were so qualified or interested, wanted to review and sit in on training as part of the assessment. So some quite practical things, even I think nominating to be part of the Work Health and Safety Committee. So there's a number of quite practical things that can happen. We've certainly got the theory, and to reinforce what Cynthia said, Standard 8 certainly is a much greater improvement than what we had under the previous system. There are only 4 standards. This new single quality framework gives us the basis. But we would say, particularly with our lived practical experience at Bupa South Hobart, there's a lot more other things that could happen as well to flesh that out or to give it some sort of materiality.
Can I just follow up on one matter, which is, in a way, it's the sort of central paradox in this case study, and it's this. If one examines on paper the clinical governance framework that was there, if you just took a snapshot in the middle of 2018, went in to do an audit, there's a range of committees which appear from the description of the work of those committees to be addressing many of the matters that you would require under Standard 8. But what we've seen in the examination of the evidence, and the witnesses from Bupa have all largely conceded this, is that for one reason or another that didn't really work to ensure quality and safety outcomes at Bupa South Hobart. You've all been in there, you've looked at the evidence that I'm talking about, and you've looked at the governance framework. Are you able to assist the Commission in understanding, from your perspective, starting with you, Mr Engler,
sure,
why didn't it work in this case?
If I could start most broadly about the industry, and I've thought about this, generally as an industry we've certainly seen an increase of residents coming into aged care with much higher acuity, effectively staying in our homes, months not years, usually with a high level of either documented cognitive impairment in terms of dementia and or heading towards a later stage of life, if not formal palliation. I think that what's generally happened, and it's just part of the context, and certainly my reflections on South Hobart would reinforce this, is that we weren't able to adjust our framework, however the single quality framework has now remedied that, to identify high impact risk clearly enough, as urgently enough as it needed to be. So in effect, and again this is clear of all of Australia, we've lost the distinction between high care and low care. Most of our residents, particularly our new admissions into aged care residential settings now, require a level of risk analysis that we'd better call high impact risk. There are some absolute elements that need to be measured more frequently, more quickly, almost in a 24-hour, 7-day-a-week cycle. Things that could happen at 3 o'clock on a Friday afternoon now can't wait until Monday till they're picked up, particularly if you had a long weekend in there. That's the sort of sense that I get, and the confidence that I get from the new Standard 8 of organisational governance about how the risk management system needed to be more finely tuned, more calibrated to the high impact residents that we're getting. I might let Cynthia or Maggie add to that?
Might get Dr. Hirsch involved in the conversation. You've been patiently quiet down there.
That's all right.
From your perspective, working as an advisor and the experience you've had in the aged care sector,
Yeah.
would you like to add anything to Mr. Engler's observations?
Yeah, I think that it's very important that there's a deeper understanding of the chronic disease conditions that are coming through now as we're seeing people living longer, the higher levels of cognitive impairment as well, and adjusting to reflect the individual needs that are required. So that whole concept of high impact clinical risk is a very important one. It's something that we've done a lot of work on around clinical handovers, so on a shift change. It's 3 times a day. You're actually having these conversations and adjusting the lens of the clinicians to understand where are all those risks and where do you need to guide your care teams. And it's incumbent on the registered nurses to really understand that. And there's a lot of training that we've done around this, and I think that actually that's made a difference. I'd like to think that that's made a difference in the homes that we've been in, and certainly within Bupa. It's like having a triage focus. It's like when you go into an emergency department. I don't want to be alarmist here because I don't want aged care to be seen as all about ill health and frailty.
Yeah.
Quite the contrary. I think our focus needs to change off that, but in relation to risk and clinical risk, I think this is quite an essential area of focus. Yes, understanding that and training your thinking every day. It's like airline pilots. It's like going through your checklist, making sure that everyone on your plane or inside your residential care home has got the needs that they need to have met at that time.
Well, I understand that at the general level. I wonder if I could just sort of descend a little bit to the specific of the Bupa situation. So it's the apparently robust governance framework which was there that doesn't seem to have held up in this instance. And what we're trying to explore is, from your perspective, you're able to help us to understand why. Was it not as robust as it looks, or was it a function of a failure of information flow? What do you think we should be focused on in trying to understand it?
Thank you, Mr. Rosen. I understand what you're asking here, and I think that it's multifaceted. It's multifaceted in the sense that information exchange in a timely manner from a big corporate right down to the grassroots doesn't necessarily flow easily. I think that it would be fair to say, and I think, this is true in Bupa, but I think it's true in other sanctioned environments, that it's a new concept relatively for the industry. We've never seen so many sanctioned homes happen. And so there's a sense of wanting to hang on to business as usual, a failure to understand the need to remedy quickly. So therefore, you need more resources, you need more focus, you need to have that leadership. I would say also that to cut through everything around whatever documents there are or work information systems there are, to speak to the residents themselves, to actually understand about the lived experience, to me is a central pillar for how we need to operate in the industry now with these standards and going forward into the future. Whilst we have these governance structures and we might have a lot of clinical risk management systems, we're failing still to really develop a robust way of understanding the lived experience and quality of life. Because quality of life can be measured, and it can be measured in a sophisticated way and is being done internationally.
You draw our attention to some of those measurement tools in your statement, don't you?
And I think, and I had tried with the Department of Health when they were looking at these standards to ask them to pay attention to this, because that is, after all, the reason why we have aged services, is to enable, not necessarily care for, but enable people to have the independence and that ability to live a long, fulfilling life right up until the end. And I think what we've done, we still see, and a lot of what we've heard over these last couple of days, is the issues around high impact risk and the lack of the basics of just getting care right. We need to balance that. And we need to be able to understand about the experience, because people will have pain, but if they know they're going out for the day to do something they enjoy, that pain has to get managed. Like, a lot of this comes as if you change the way in which someone can have a good life, then all those other clinical matters have to be addressed. They just have to be addressed. You can't go out the door with a weeping wound, for example. So.
Ms Payne, can I test a proposition with you and then invite your colleagues to make any observations they want? One of the things that comes out of this case study, at least some of the evidence, is that there was a heavy emphasis on cost cutting in the implementation of certain programs and apparently less concern about the potential impact on care outcomes of the implementation of those policies. I'm talking about there's Project James, and there was the Bupa Model of Care 2, which were introduced in 2017. The proposition I'd like to test with you is, would it be beneficial from the point of view of care recipients, the elders, to use your term, for those on the boards of approved aged care providers to have a positive duty to consider quality and safety outcomes in their decision-making processes? And I'm thinking of an analogous position we find under workplace safety law, where directors, people like yourselves in organisations, have a positive duty, due diligence duty, to consider health and safety aspects of the running of the business. Do you see that a role for that potentially in aged care legislation?
The best way I can answer that is to even think about 10 years ago, and I think this is related. It was not uncommon in the board structure of governance that typically you might have a treasurer and anything to do with the financial management of whatever that governing body would oversee, there might be a deferring to the treasurer. And the industry and the profession of governance recognised that that was actually not correct. And many organisations removed their treasurers because the general consensus was the whole board actually needed to understand financial management. I put to you that just like that circumstance, clinical governance equally needs to be understood by all board members. So there's a skills mix and a capability that I think these new standards is absolutely impacting. So some organisations I'm aware of didn't necessarily have someone that had a clinical or an operations management background on their board, and I truly can't speak for Bupa. I don't know the answer to that, and I don't know the answer to those prior circumstances, because obviously you mentioned BMOC 1 and Project James. Yep. I've heard of them since I've been connected to the organisation, but clearly I don't know what they are.
Yes.
But it is behoven on the board to understand the business that it is governing, and so the skills matrix actually is quite an important element of that.
We don't, that notion of a skills matrix is often referred to in governance guidance material. We don't see that in Standard 8 though, do we? Not explicitly.
No. So, and if I revert back to my earlier point to you, Mr. Rosen, about performance isn't just necessarily about the standards. Organisations have strategic imperatives, visions, missions, higher order purposes. So the performance is actually about that. So our meta frame that we use as a business is business excellence as well as the aged care standards.
Mr. Engler, if I could turn to you, and you can make any observations about that question, but I'd also like to ask you some questions about organisational culture, because that seems to be a very important aspect of the notion of governance and the ethical responsibilities of people involved in running aged care service provision. Do we need, or what should this commission be considering in relation to that? Is there a need for policy development, legislative change, improved standards? What would you advise us?
I'll just go back to reaffirm what Cynthia said about the prior question. Absolutely, there needs to be a more direct link between the skills on various boards or governing bodies, particularly with the business of residential aged care. So they need to be linked into those. In terms of the culture question, and it's that old adage about, culture eating strategy for breakfast, it's most important that organisations, and we enjoy working with these new standards. We enjoy working with the more comprehensive standards under the new single quality framework. I think it would be fair to say that they are, if you like, halfway there. The cultural aspect, or trying to capture, whether it's policy or through legislation or behaviour or a system of star rating, whatever, the way in which those governing boards, the decision makers, are linked in directly back to the consumer experience. And I think we'd be open to whatever situation, whether it's comparing from overseas or from other industries, what ways that's done. But certainly we I think, are part way down the journey. There's certainly a long way to go. Sorry, just ask me the question again, Mr. Rosen, about what's...
It was this somewhat vexed question, really, of organisational culture, which is it's almost a cliche in some ways, and yet it's hard to think of anything else that captures the idea of ethical operating, which in the aged care sector would seem to be a very important aspect of good governance, given what's at stake if governance is poor. So it's really how to promote that sort of good organisational culture, whether that's an entirely internal thing or whether there's a role perhaps for the regulator in some way to assist in the promotion.
I mean, in terms of operators, for managers being involved, and I think we could all personally attest, those of us who enjoy working in aged care, working with our elders, nothing can replace the experience of sitting one-on-one with a resident and talking to them. That very subjective way of understanding how someone's lived in real experience is very informative. So even it sounds a bit tokenistic, but even the requirement of operators to spend time within their facilities, spending time with residents, some sort of formalising of the arrangement or the way in which that information is communicated up and down, not just with their local centre, but with the actual lived experience of the residents, or their representatives, I think would be welcome. I'm sure there's a myriad of other ways, but absolutely anything that links back in, not necessarily in a punitive way, but more in a way of promoting the engagement in a cultural way, would be absolutely welcomed, I'm sure.
More carrot than stick you're advocating.
Yeah.
Dr. Hirsch, is there anything you'd like to add to
I completely support what my colleagues are saying. I'd just only add that the modelling of culture needs to be at the top. So the way in which you want to care, be compassionate, to really connect with the core reason why you have that business in the first place, you need to model that behaviour and be genuinely interested and be authentic in the way in which you operate from at a board level right through down to the grassroots. So I think culture is very much essential. A positive, supportive, caring, compassionate culture is really what's needed to be promoted. And you can have all the models, work instructions or anything till the cows come home. But you're going to have a lot of problems with motivating staff if, for instance, they're afraid of their jobs. It's a punitive environment, and I think that there's a role perhaps for the regulator to have a slightly different approach that really does support more of learning organisations than ones that are kind of being where there's punitive action that happens. I think there needs to be a balance that's struck around that.
Can I just jump in there and give, again, a practical example? In aged care, again, at the moment we're talking about specifically for our experiences, residential aged care, but I'd be surprised at the infrequency with which any operators spend time in their residential facilities, to the extent to which, and I'm privileged to be sitting beside two of my colleagues who've done this most recently, spend a night in the facility. And I know Maggie last night or most recently spent a night in the dementia or the memory support unit. Again, that might seem a bit odd and at one level almost tokenistic, but it's absolutely important that level of genuine, real engagement is at least thought of or entertained by people, that they would go to that extent, not just visiting, but living the experience, seeing what it's like to be a resident overnight in one of those homes. Again, I think practical examples like that could really benefit the industry.
Perhaps if I can explore that with you. We've had evidence of CEOs who have not only spent a night in an aged care facility, but sat down, shared meals. That very practical, tangible. We're in this together type statement. Is that the importance of that? Is that why that matters?
Absolutely, it informs, and I suppose what's good about it, it can't be manufactured. It's absolutely authentic. Not only is there's the information there, but it's real and lived from your own experience. You absolutely know what a noisy trolley sounds like at 4 a.m, or you know what it's like for someone to knock on your door to check how you're going with the torch at 3 a.m. Those sorts of things, I think we can often. There's an old saying, I live in somebody else's workplace. The way in which a lot of our task-focused processes and systems are really geared around the work requirements rather than the lived experience of the resident in a home setting is something that commitment to authentic participation could really improve.
No,
this point.
I really echo the importance of those concepts, because our success as an organisation supporting this compliance remediation
Yes.
area is directly connected to these concepts. How you help bring forward the voice of the experience in that home, and the timing of the new standards actually is very good, because it means that in this change management or transformation process, people like us are able to enable, and the key word there is enable, a speed up of connection. So I would say to you, in an organisation the size of Bupa, I don't question motives of people. I think culture is just the way we do things, and transforming when you're in that environment and that's what you know, it's very hard to disrupt yourself. Whereas when you have people like us that actually come in and we are a fresh pair of eyes and we help unleash that consumer experience in a really constructive way that helps enable that through the organisational systems and processes. I mean, the things we do in terms of educating and mentoring and coaching and putting in the basics like high impact risk, being able to get the hygiene factors, mobilise the teams that are there, because it is quite overwhelming when a home is initially sanctioned. There's a period of shock, there's a period of what have we done wrong, and to move into a mobilise phase, you've got to get a plan together and you've got to help people understand what are the priorities, and I think that's a really important part of what we do.
Mr. Engler, can I just take you up on the carrot-stick divide? Lawyers love sticks, but I'm sure there's a place for carrots too. What do they look like in this area? What can a regulator do to encourage improved governance, better organisational culture and so on? What do you think?
My off-the-cuff comments around this would be, I've not reported on this in my submission, but that at the moment we have a very brutal tool. It's either on or off, you're either met or you're not met.
Yes.
I think there needs to be a sophistication. Cynthia's mentioned the Business Excellence Framework. There are a number of other accreditation systems that exist around the world or in other industries that are more nuanced in terms of, say there's 8 standards, you need to get a certain minimum number in 2 of the 4 clinical, but you need to get a score of 75. I think in childcare, for example, in this country, we talk about exceeding, met, developing, some sort of way that we can graduate the way in which operators are complying and actually reward ones that are better than just met.
Yes.
They're excellent. So I think that more nuanced way and encouraging people, ultimately, I think you're right, you need both carrot and stick, but I think if the carrot's old and gnarly enough and you hit it over someone's head, it becomes like a stick anyway. So I think that we can get both.
Your reference to childcare, I saw, brought a smile to Commissioner Briggs's face because she has considerable experience.
Okay.
Might prompt a question in due course. One final matter for me, and it's a more prosaic sort of factual matter that I want to explore with you. If tab 163 could please be brought up on the screen. You might have been in the hearing room when I asked Ms Webb about this email exchange between you, Mr Engler, and you, Dr Hirsch, and the manager of the home, Ms Woodorth, and Ms Webb, who was the operations manager. Without going into the detail, it seems pretty clear from the content of the email that as at July 2019, so that's July this year in the post-sanctions period, there was a proposal, presumably from within Bupa, to implement some staffing cuts at Bupa South Hobart, a proposition that you two were resisting strongly, as I read it. Have I got the narrative right?
Yes.
And where was the push to reduce the staffing coming from, as you understood it? Are we to assume it was Ms Webb because that's who you were writing to, or is that too simplistic?
You can start off.
Dr. Hirsch?
Yes. It was a request for support from the General Manager.
Yes.
After receiving a request, as I understood it, from I think it was from Davida. The request was to write to Davida to try and get support to have the this not adjusted. I sat with the general manager and looked at the staffing. We laid it all out, and she was trying very hard to fulfil a request that was more of a centralised request from Bupa.
Yes.
And I wholeheartedly could see the problem, and we discussed this. So therefore, this was the email.
This might be a bridge too far, and tell me if it is, but does it tell us something that after this entire saga, the sanctions, they come out of the sanctions period, and then it seems to be back to let's reduce staff to reduce cost? Is that too simplistic?
I do think it's a little simplistic, because when you look at aged care generally, there is a really serious issue around viability of aged care homes currently.
Yes.
And I think that Bupa is like other homes, where they've got to be responsible around, you know, how they manage the financial aspect to this. So I think it was a consideration for sure, but the response was met positively to say no. And I think in a way it was helpful for us as an independent body to provide some additional line of sight for the consequences that could happen, that if otherwise were to happen again, it's exactly laid out in that email as we saw it.
Can I just add to that, if that's all right, Mr. President? So I think that the line that we haven't yet read in the email, which is at the top, that says, Maggie, are you and John both able to continue at South Hobart for the transition period of 3 months? So that's predicated around Bupa generally, and particularly for Davida, understanding that although the formal sanction period was due to end, i.e. the legislative requirement to have an administrator and advisor, that certainly at another level, more strategically, there was definitely the penny had well and truly dropped in terms of understanding that despite not needing to have no compunction to have to keep on administrator and advisor, good homes would see that you needed a transition plan, and you might as well keep going with the people that you've got. That would be the best way to get sustainability.
I understand. And there to get some credit for that is what you're saying to us.
Yes, that's right.
Yeah, I'd have to agree.
Now, finally, you have very kindly, through your lawyers, provided us with a document which is in the form of some key recommendations for reform. I don't think we're in a position to put this up on the screen. I'm looking around me. We are. No, we don't. Okay. Do you have copies of this document
Not in front of
you?
us.
I think we have some hard copies which we can distribute in the old-fashioned way, including 2 for the commissioners if we have them. Thank you. Doesn't matter.
Oh, okay.
Thank you. Your name appears first, Ms. Payne, so I'll get you just, if you could briefly, to explain what this is, why you've given us this.
I would say to you that there's an opportunity, given that we are in a point in time as part of industry reform and transformation, to reflect on what are the constructs that exist at the moment. And if it's okay, if I could just speak to the first point.
Please.
The terms administrator and advisor we think should be replaced to a new term called compliance remediation specialist. And this comes from an experience that in every situation it is initially very difficult for the approved provider, the key personnel of the home, to actually understand what is the role of advisor and administrator, because in some instances it is not as clean and black and white as one would assume. There are different skill mix. So if I use an example of the 3 of us sitting before you, we bring different elements to bear, and it's important, I think, that when an approved provider is selecting a compliance remediation specialist, they're able to understand what those skills are, and I think the current term advisor and administrator don't help that.
Yes.
And we think that the Aged Care Act does need to have a clear definition of the duties and obligations of a compliance remediation specialist, and that they should be required to undertake some specific training and be certified because of the complex nature of the work involved. We think it's a good idea that there is a register caused that makes available a record of our skills, our experience and our track record, and that register be centralised with the regulator, knowing that from 1st of January 2020 the functions move fully into the Aged Care Safety, Quality and Safety Commission.
Yes.
And there are questions around how that might work, and I'm sure those senior policy holders are working through that, because there is no direct connect at the moment with the Aged Care Safety and Quality Commission, except in the course of interactions at an assessment visit. On the Department of Health side, there are weekly calls and phone calls that happen between the home, the advisor administrator and the approved provider, and that there should be some standardising of the reporting obligations. This is particularly relevant, I think, for Bupa South Hobart, that in the circumstance when an accreditation is expiring, the Act doesn't allow for any continuance during a compliance remediation period. And it's important to note that Bupa South Hobart, its accreditation expired in the first 3 months of its compliance remediation period, which is not enough time. It underwent an old standard accreditation visit. It achieved 6 months, and whilst it was still in its sanction period, it underwent a second accreditation audit against the new standards. And that is an enormous amount of work and pressure in a very short period of time. We believe that once the home is remediated, a review audit is caused by the regulator and a reset button for the accreditation going forward. And we think that an assessment framework to track the improvements and the approved provider's performance during the sanctions period. At the moment, it's predominantly through a phone call with the Department of Health, and then obviously through the assessment visits that are conducted by the Commission. We believe that a compliance remediation plan should form the basis of the relationship between the compliance remediation specialists and the approved provider, in order that it sets out the connection to the training plan, and that is checked in a different way to the home being assessed by an assessment visit.
Thank you, Ms Payne. I should tender that document, Commissioners.
I suppose.
Well, I'm in your hands. I mean, it's one way of being able to identify it if need be. It's really only for that purpose.
Well, certainly we should receive it. I don't know if it needs specific tendering. It's not evidence, is it? It's a helpful submission.
Yes.
I think we'll receive it. We'll receive it with great thanks, I might add, but I don't think it needs to be tendered as a...
I'm quite content with that. I should just perhaps add, if I may, on behalf of the Commission, that if you were minded to put in any more detailed document than this, then that would, I'm sure, be welcomed by the Commissioners as well.
I think we can positively add to that. Some of these suggestions are interesting, although the degree of interest might depend upon some of the details.
Yes.
So, I mean, for example, just to take something off the top of the list, where you're talking about specific training, well, I'd be really interested to know what that training would be, and whether there's anybody that you think at the moment is providing that training, because otherwise we would be making a recommendation that wouldn't go very far.
If I may answer, I think at a minimum you would expect that the compliance remediation specialist has undergone a robust training in the aged care standards.
And who does that you currently know that does it well?
Well, I would be looking to the Aged Care Safety and Quality Commission, that they would provide a specific program that connects into this area.
Yeah, well, anyway, that's
it doesn't exist at the moment, Commissioner.
That's the point, and so that's why further thoughts would be really good. It's a really great idea. I really echo the thanks that I said earlier on that Mr. Rosen foreshadowed on our behalf. We're delighted to have submissions like this. And every time we do, we sort of ask more questions, so feel free to add to it.
Okay, we will.
Yeah, we will.
Thank you.
And perhaps if I could just add to that, Commissioner Pagoni, the Commission could learn from other related areas. So, for example, there are approved environmental auditors under environmental protection legislation with a register. There are processes under which health and safety regulators provide training for health and safety representatives, for example. So there's a range of other regulatory environments that perhaps could be drawn upon by this Commission. I see you're all nodding.
Yes.
Getting tired. Very good. They're the questions that I have for the panel.
Thank you for
Oh, sorry. I'll come to that.
Thank you for your evidence. It's quite interesting to hear these comments. Can I ask, in the work that you've done, at least for Bupa South, has the CEO or the board of the organisation sought to engage with you direct?
I'll answer that, Commissioner. In the capacity of my national role, one of the remits that I have undertaken is providing key personnel training, and that included the entire BVAC board, all of the key personnel that operate across the support office. And very pleasingly, we have more of that training scheduled. So even this coming week in Melbourne, that key personnel training is being done together with a legal specialist, and we're looking to provide more training so that key personnel joining the organisation, because there still continues to be change within the organisation, to make sure that those approved provider obligations and those key personnel understandings, what is compliance remediation and how does it fit within the Bupa context, is the focus of that training. And I have reported twice through to a steering committee called the Ruby Steering Committee, which the CEO and the Managing Director both sit in on. And I have interacted through that mechanism through progress reporting, both on the compliance remediation plan, the corporate plan for continuous improvement, plus other observations as we've been supporting the organisation through its transformation.
In most organisations, on a generalised basis, they look at the situation of a Bupa South Hobart, or as Southern Cross, as we heard earlier in the week, and they go, well, we're doing all right. And they walk away. And I think the evidence that at least I've heard over the course of the year lends me to the view that it's very easy for an organisation to fall into, for want of a better word, disrepair. And so I want to ask you a question around a thing that I would call loosely a health check. Mm-hmm. So the regulator comes in and does an audit. Where's the health checking in this system? Do you see much of other organisations or facilities actually going through a reasonably rigorous process of either internal or external review about their performance against the standards and the expectations under the Act?
I would answer that, Commissioner, by saying that agile aged care organisations, that is actually part of their DNA. So in that quality management system and having a whole of business approach, it is indicators, it is internal review. We advocate for third-party audit, and what that means is not only external review but also benchmarked indicators, and being able to compare your performance with a larger pool of aged care providers is actually very important for both clinical governance and governance in general. But it also provides information to the managers of the service as well, because they get to collaborate and do process benchmarking, for example. You create a whole dynamic of data translating through knowledge into information and action, and that's what's kind of at the heart of it all, is making sure that you're not just insular, you're not looking just at yourself, you need to have external. And I think in a sanctions process, that's why the success of a transformation in what is actually a relatively short period of time, 6 months, sometimes longer, having people like ourselves being able to mobilise and enable that change is quite helpful, because we are a separate pair of eyes.
So, how often do you see that kind of agile approach?
In organisations I've been connected to, it can be as frequently as every 6 months, organising an internal review. To do that, you need to have a good understanding of your own quality management system. What does good look like for you? And when you know what good looks like, the boards know what good looks like, senior management knows what good looks like, management at the home level knows what good looks like, you can create alignment, and therefore the feedback that comes back into the organisation doesn't then become one of blame or defensiveness. It's one of genuine continuous improvement, because you embrace that feedback in the spirit that it's provided, which is to keep improving.
Can I just add there that it would be one thing for organisations like Bupa, despite its size, to be able to compare itself with its peers in aged care. But Cynthia's made mention previously of the business excellence framework. The real test is when you can compare yourself to other industries, whether it's banking or telecommunications or councils or whatever. If you use a standardised approach using a business excellence framework, which has finance and people and outcomes, all sorts of measures, you really then can absolutely, fully objectively see how well you're doing and how well you're performing. So not just against other aged care, but against other industries, both locally and internationally.
Thank you.
I see that your document has got up on the screen. I don't know who's given it that name, but we might perhaps change the name to Anchor Excellence Recommendations. And I know how Mr. Rosen loves to have things recorded in all sorts of places. I'm sure it's childhood carryover. So why don't we put that in your tender bundle? Would you be happy with that, Mr.
I'd be thrilled. Thank you.
I thought you might be.
Before the witnesses are excused.
Before that, I'm going to ask them a question, if I may.
Yeah.
But unless you want to do something before that.
No.
In the context of the Commission, I've not yet seen very much of what I see in other contexts, and it may just be that, as is public knowledge, I haven't been involved in the Commission for as long as it has been going. But in other contexts, it's common for corporations, as part of the auditing process, to have a detailed management report. So the auditors will be appointed, and the auditors at the end of the day need to simply provide a report, which is often in very general terms, and it's either qualified or unqualified. And if you read the auditor's report of most companies, you'd be left wondering how they justified their fee. But before the report is given, there's often a detailed management report that the managers of the corporation get and the directors of the company get. Now, I'm not sure whether something like that, but for the quality of care, might be something that you think would be appropriate. It really picks up the point that Commissioner Briggs asked about the health check, and also her question about how frequently the health check should be undertaken. Do you wish to say anything about that? Any of you?
You go first. We've always got something to say.
Yes, so I feared that.
You asked.
I think the three of us certainly are used to working in organisations where that monthly board reporting, both of management that then gets teamed with generally the financial statement or the financial, the books as it were, every month, and then annually that gets looked at, obviously by external auditors for the financial sign-off. But I think that's an absolute, say no-brainer, but it's a natural conclusion, and again, a maturity of, I think, Standard 8 of the current standards of the single quality framework would require some type of qualitative monthly, quarterly, whatever it was, rolled up report that showed how well each particular, in this case, home was doing against the others, and again, benchmarking against other industries, against other aged care providers, and then ultimately other industries. I think that's a natural conclusion that will come from this.
So presumably, consistent with what you said before, that would need to be done by somebody external and independent.
Well, I think it's both. I think it's monthly by the internal staff, as in a normal company has its monthly board reports, and then it gets audited annually. And I think you're right, in the same way that we assess financial financial performance annually, that similarly would look at the quality and the outcome of performance based on outcomes, not just inputs around care, and the quality that's provided would also be audited in a similar way. Sorry.
No, my reflection on that, Commissioner, is I think having a statement of quality and safety that could be made available to elders that articulates what the actual organisation does as part of its quality management system and how it goes about informing itself that its systems are working and how it engages consumers in that process. And having, for example, the Aged Care Safety and Quality Commission reviewing those elements to give feedback to the approved provider would be enormously helpful, and I think it would also help consumers to better understand the organisations that they interact with.
Well, you see, there's the beauty of the detail, because the model that I was putting to you was an external auditor's model going in and doing the health check that Commissioner Briggs talked about. But an alternative to that might be the kinds of things that one sees actually much more actively in America, but even in Australia, as school councils, a kind of a consumer group. As between those two, do you have a preference? And if so, why?
I'm going to defer that one to Maggie.
I think that there's an added complexity, Commissioner, around the higher levels of cognitive impairment people are experiencing when they come into residential care. And it takes a particular type of approach that I think is very important, that we develop a system that's inclusive of their feedback and their views. I know I've raised about quality of life, but I do know that there's very well established models in the UK and internationally, and I have it in my submission, where there's a mixed methods approach of going in, collecting a lot of data, and it's quite efficient how it can be done, and that can be compiled around really good quality of life outcomes that can be benchmarked not only nationally but internationally. And I think that there's huge merit to look at this. You've heard evidence from the Whidden Group. You've heard evidence from others that have used various parts of this model called ASCOT. I think it's very well worth looking at that again, because if we're going to tie governance to the resident experience, and that's what then guides the quality and safety of care, then we need to link that in an appropriate way.
Yeah, so my experience in outside of the aged care sector is that to have users group as the mechanism for the health check is a recipe for disaster. That you end up having the users group captured by particular people with an axe to grind, and it produces distorted outcomes. But I'm keen to have your views about that in the context of the aged care sector, and whether you think it would be better there rather than an independent kind of external auditor model, which I had thought you were hinting at with the one-pager.
Look, just to continue with my thoughts about this, is that it does need, I would actually separate the regulator around safety and have an independent body that's around quality. I think that it's very hard to marry safety and quality together into one organisation, and I think that if it's the government's role to make sure that in the public interest everyone is safe, then then that's what it should be looking at in terms of minimum standards and compliance. But when we're actually missing a whole area around innovation and a whole opportunity to be, amazing with the way we provide aged care. We're currently very bogged down in a sense around the regulation side. So if we look at the way in which we engage with residents, I think your point of the users group as such, I think it's more around sampling, shall I say, around how you set that up within each of the homes, and we've been doing a lot of that, and that just naturally evolves. I think it can become, I think there's a method in which that could be done, and you can safeguard against, I guess, that going into a sort of a axe to grind type of scenario. Yeah.
The regulator in their work now is doing this with 10% of residents in homes, and they say they're learning all the time how to improve it. From my angle, one of the things you're really talking about is transparency, and this industry, like many other industries in this country, has been reluctant to have transparency, I think. So do I take that as one of your key messages, or have I got that wrong?
I think you're 100% correct that transparency is the foundation around what we've discussed with you today.
Good. Yeah. Thank you.
Now, finally, all this is good and well for a big organisation, but what about a small organisation in some rural area?
Well, I mean, South Hobart is actually regional, so even though it is part of a large organisation, we have supported standalone small organisations as well.
But small organisations that don't have the Bupa backing, where it's a standalone with nobody behind it, might be a different kettle of fish. Any thoughts about that?
I would probably argue in the reverse, in that sometimes if a standalone facility has its board that literally meets and has its boardroom in the facility, they can't help but have active engagement. There's actually a perverse or a closer understanding the smaller you are. Sometimes the size and scale of organisations, particularly who are represented in rural, remote and regional areas, who have various head offices in different cities sometimes for different functions, that's a very difficult beast to make sure that the governance line that's drawn between the top of the organisation right through to one person's experience has to have a lot of energy. I think sometimes the smaller organisations, as I say, because of environment or geography, where their board meets in that building, where their officers are meeting in that building every month, they cannot help but be a lot more closer to the action. I think that's somewhat ironic, but the smaller organisations can in fact be quicker at adopting and adapting to this.
Thank you. Mr. Rosen, you had wanted to say something a little while ago.
Just one final small question, more a clarification really I've been asked to make with Dr. Hirsch, and that is just to clarify with you that whilst you're a doctor, you're not a registered nurse presently.
This is correct. I sadly let my registration go in 2012. So, and when you referred to me previously as a nurse advisor in relation to this email, I'm very careful to make sure I'm not considered as a nurse anymore.
Okay, I understand. Thank you
it's
for that
still
clarification.
In the blood.
Yes, I'm sure. They're the questions that I have for the panel, Commissioners.
Yes, thank you. Thank you for coming to share your views with us and your enthusiasm, I must say. That it's infective and infectious, I should say. Thank you very much. And
thank you, Commissioner. Thank you. It's an honour.
Formally excuse you.
Yeah.
Thank you.
Thank you. That concludes the evidence for today.
Yes, what time are we starting tomorrow? What time?
10.
Adjourn to 9:45 tomorrow, please.